Sound check from the Philippines. Sound check, sound check.
Hi, check 1 2. Can you hear me? Check.
They are not unmuted.
ಬರ್ತಾ ಇಲ್ಲ.
That is Philippines Hub 2. Can you make them the one done now?
Just message.
Yeah. Done?
ಬರ್ತಾ ಇದೆ, ಅಲ್ಲಿ ಓಪನ್ ಇದೆ.
What? Okay.
Sound check. That is sound check, sound check.
Sound check. Sound check.
It's okay. Yes, sir. Check. Sound check 1 2 3. ಇಲ್ಲ ಬರ್ತಾ ಇದೆ ನಿಮಗೆ. ಇದರ ತೋರಿ ನಮಗೆ ಅಲ್ಲಿ ಬರ್ತಾ ಇಲ್ಲಲ್ಲ. ಇಲ್ಲಿ ನೀವು ಕೊಡ್ತೀವಿ. Hello. So pleasant morning to everyone. Welcome to India for our international guests and people joining from multiple countries. So keeping in mind the time zones that we are catering to, I think Australia, Adelaide will be the farthest, and moving from there, the Philippines, Indonesia, Bangladesh, Nepal, Malaysia, and India. So we have a plethora of participants, panel speakers, people participating in keynotes, roundtables. So it is going to be a 2-day extravaganza of aged care experts coming in here. Ladies and gentlemen, it's my proud privilege to welcome you all to this beautiful city of Bangalore and Ramaiah Medical College, part of Ramaiah University of Applied Sciences. I take this honor to initiate the program of APAC, Asia Pacific Aged Care Health Hub International Policy Forum, and we will have the official proceedings, so to speak, from 9:30, but this is an introductory session just to go through some of the house rules and where we are and the exits and other general briefing. So we are in the Medical College building. This building is the Ramaiah Medical College, situated in the Gnana Gangotri campus. We call it as the GG campus. The university has two campuses, one at Pinya, which is the technical or the engineering campus, RTE, and this is the Ramaiah Medical College situated in the Gnana Gangotri campus. We have the restrooms. We are sitting in the council hall on the ground floor of the medical college. When we move out onto the left and right, we have the restrooms, and tea and coffee is being served in the yoga lab. The lab where we are having the tea and coffee and breakfast. It's on board. We'll be having it across the event, so you needn't have to wait for the tea break to go and have your refreshments. Additionally, you will be having bio breaks in between the sessions, and since we are running across different countries, in keeping up with the time, we would want to ensure that the sessions are held on time, and if there is a slight spillover, probably we will try to cover it up during the lunch and the tea break sessions, so we might be keeping the sessions running without having that exact break. In addition to that, like the session today is being attended by participants here, which is the physical hub for the Asia Pacific Aged Care Hub International Policy Forum. Additionally, we are having satellite hubs at different locations from where the fellows for this Australian Awards program are representing. So we have in Nepal, we have in Malaysia and Indonesia, and Philippines. Participants are having a hub over there, and they are attending from there. Apart from the satellite hubs, we also have online participants participating across these countries which I mentioned. So just to ensure the semblance of uniformity and also having people to participate in a very democratic manner, we have the Zoom platform, and there is a single unified link for the entire conference. So what we have ensured is, unlike some sessions where you might have had multiple links, breakout sessions, and rooms to enter with different task codes, we have tried to have a single link so that the ease of access is ensured, and the participants can mention in the chat box if they want to ask a question. So for the panel sessions, we have the format, just to run through the program that would ensue for the next 2 days. Probably I'll request if you can share the program. Today is the starting day, and we'll be having the sessions kick off at 9:30. All the times I'll be referring to will be in Indian Standard Time. So please apply the requisite conversion factors. Since we are having a multi-country presence, we will ensure the conversion factors is at your local time, and the event invites have been sent using the Google Calendar, so that the times that are mentioned for your relevant local zones are applicable. So I will be saying the Indian Standard Time, which is at Ramaiah Medical College, Bengaluru. So we'll have the first keynote session at 9:30 a.m. and followed by 2 more keynotes from Dr. The initial session will be with Dr. Nambiar, then Amrita, Kansal, and Dr. Toshima. Following it, we have a small inaugural program at 10:30 a.m. Indian Standard Time. Again, being a hybrid inaugural, we'll be having people participating in person at the center at Ramaiah, along with representation from multiple countries. So in that context, there will be short videos, there will be live online presentations, and people from the hub at Ramaiah on the dais giving their initial comments. Following the inaugural program, we have the panel sessions. So the panel sessions will have a convener who has interacted with the chair and co-chair of the sessions to invite the panelists and have a discussion around the themes that have been mentioned. So for these sessions, we have participants again from international and other hubs. So we would request them to name their hubs as per their location, so that it's easier for us to make them as co-host for the event. So you will be having all the rights to share and participate as if you're live here at the venue. So the panelists will be able to make their presentations using the audio and video, and we are going to pin the videos of the people who are there on the panel onto the main screen so that everybody would be able to view it. During the panel discussions, we would request the other participants to just post the questions, if any, to the panel, which will be on the chat, and the convener and the chair and co-chair would try to address it at the end of the panel during the discussions. So in order to ensure that everybody gets an opportunity, we are not opening the questions to the general participants at the end of panel discussions. It would be routed through the chair so that there is some sense of order in it. So following the first panel discussion between the 11:30 and 12:30 p.m. Indian Standard Time, we have the paper presentations by the scholars. So several faculty, students and postgraduate students and other researchers working in the domain of aged care have communicated their papers for paper presentations. Again, to ensure it's very easy to access, we have a separate Zoom link. So there is a single link for the entire event comprising of the panel discussions, roundtables, and the keynotes. Only for the paper presentations, there is an additional link, and we will ensure that the paper presentation is also beamed through the main link, and there is a live streaming, so you can watch the paper presentations using that. But the participants who are going to present the paper are required to join using the other link. So in case you have any queries or questions, please drop in a mail to APACH where you have got your confirmation mails, and we are going to respond to it. Subsequent to the paper presentation, we have the lunch break between 1:30 to 2:30 p.m., following which we have the second panel discussion on policy and regulations in aged care, challenges and opportunities. From 3:30 to 3:45 is the tea break, and the round table discussions on role of technology, innovations, and industry in aged care will commence from 3:45 p.m. and it will end at 5 p.m. So this is the program for the day, and evening we are having a dinner for the participants in Bangalore. The venue is Century Club, and we have arranged a few vehicles. What I would request is please talk to the registration desk and confirm whether you would be joining from the venue here, and the vehicles would start around 6:15 to 6:30. We request you to be here so that we can take you to the dinner banquet at Century Club, the location of which is shared. Tomorrow on 17th, the day would start with keynote at 9 a.m. And it would be an online keynote by Professor Sue Gordon, followed by another keynote by Mardit Weiss from Asian Development Bank. The third panel session would commence at 9:45 a.m. on 17th, that is tomorrow, and the theme for it is Clinical Geriatrics, Global Challenges and Local Solutions. Subsequent to these panel discussions, we have a short tea break between 10:45 a.m. to 11 a.m., followed by the fourth panel session. The theme for the fourth panel session is addressing the challenges of aging population in developing countries. Following the fourth panel session, we have a keynote session, the third keynote sessions on global perspectives in aged care. So we have three speakers, keynote speakers from Philippines, Australia, and Professor of Epidemiology, Dr. Nora Hari from Malaysia. Again, tomorrow also we are having the keynote, following the keynotes, a paper presentation session between 12:30 to 1:30 p.m. So these paper presentations have been sequenced in such a way that the online presenters finish their presentation, following which we will be having the offline at the center presentations in Bengaluru. The Second roundtable would commence post-lunch at 2:30, which would be a session exclusively for the fellows of this Australian Awards program to share their experiences and also the outcomes of their activities that have happened over the last 1 year. Following the tea break, we have the valedictory session between 4:15 to 5 p.m. and that would be a closure session for the event. So this is in brief the 2 days program that we are having, and we have ensured that the entire program is available online at the website, APAC website, which you are very familiar, which you have used during the registrations. Please don't hesitate to drop in a mail or communicate through the WhatsApp messages which you have been receiving. And for the offline participants, we are at your service. We have a help desk, we have a travel consigliere service, and also the emergency medical team at your request if you need any help. I hope that you have a wonderful and resourceful time for the next 2 days, and we will ensure that it is a very good and great learning. Also, Bangalore is a very vibrant city, so I would request you to explore Bangalore in the evening tomorrow and also on the weekend. So if you need any help with the location and the places that you would want to visit, so you can speak to one of our team members at Ramaiah Medical College. So I would now request my co-host, Dr. Madan, to come and share a few things. Thank you.
Thanks, Nandu. Dear colleagues and friends, esteemed guests and participants from Ramaiah University in India and our satellite hubs in Philippines, Malaysia, Nepal, and Australia, and across the Asia-Pacific region, as well as our supporters and friends dedicated to enhancing aged care in the region. A very warm welcome on behalf of Flinders University and Aged Care Research and Innovation Australia, ARIA, project team. So aged care is a pressing issue in the Asia-Pacific region, and with countries like India, Philippines, Indonesia, Malaysia, and Australia witnessing a significant demographic shift. The region is home to nearly 60% of the global population aged over 60 years, and is projected to reach 1.3 billion by 2050. This demographic transition poses social, political, healthcare, and economic challenges that require a multidisciplinary approach. This Asia-Pacific Aged Care Hub, or APAC, is a transdisciplinary initiative that is led by Flinders University and ARIA with the support of the Australian Government Department of Foreign Affairs and Trade, and it aims to enhance aged care across the region. With 13 leading organizations across from 7 countries, including universities, foundations, and healthcare institutions, APAC seeks to drive collaboration and knowledge exchange for impactful academic research, industry, and policy outcomes. We are extremely grateful to our hosts, Ramaiah University, and we also extend our gratitude to our satellite hubs at Philippines, Malaysia, Nepal, in addition to Australia. Apart from what Nandu actually said today, I have 3 additional points. One, as Nandu pointed out, time limits are very strict. So I would really advise all of us, including the keynote speakers, as well as the panelists, and the other paper presenters, to be very strict in terms of time limits. The second point is that we have signed an agreement with the Healthcare Management Review Journal. So this is a Q1 listed journal, and we have the permission to write 2 thematic papers as arising from this APAC International Forum. And there will be also an opportunity for paper presenters today. We will be closely watching the paper presenters to see if we could identify a few very interesting papers and invite them to publish in the journal as well. All the panel discussions, as Nandu said, and roundtables as well, will lead to policy outcomes, and we would have a policy report that we would publish it online. So having said that, thank you all for joining us today. I would also wish to acknowledge the Australian Government, Department of Foreign Affairs and Trade, and the esteemed Australia Awards Fellowship Program for funding us. And we're very grateful for Ramaiah University for hosting us here in this lovely city of Bangalore, and a whole Flinders team and those ARIA who are actually joining us online. We are delightful to be here, and we look forward towards taking part in the interactions today and tomorrow. So thank you all. So on behalf of Nandu, we would actually pass it on now to our satellite hubs. So I wonder if we could start first with Philippines, perhaps. And our hosts over there are Professor Maria Tricia Batista and Dr. and Associate Professor Ivan Neil Gomez. So I hand it over to our Philippines hub to start with, and then we would go to Malaysia and then Nepal.
Yes, loud and clear.
All right. So mabuhay and good morning to all of you here in the on-site in our satellite hub, and to all our distinguished guests joining us from across the Asia-Pacific region and beyond. It is really with great pleasure that I welcome you to the University of Santo Tomas, serving as the Philippine Satellite Hub for the Aged Care International Policy Forum. This esteemed event is part of APAC, spearheaded by Flinders University and the Aged Care Research and Industry Innovation Australia, with the invaluable support of the Australian Government Department of Foreign Affairs and Trade. Today marks a pivotal moment in our joint efforts to enhance aged care services across the Asia-Pacific region. We are gathered here both in person at the Ramaiah Medical College in India and virtually from satellite sites to foster collaboration, share insights, and drive innovation in the aged care sector. This forum reflects our unwavering commitment to improving the quality of life of older persons, and with the diverse backgrounds and experiences, we have a unique opportunity to learn from one another, address challenges, and shape the future of aged care. So over the next 2 days, we will engage in discussions, hear from leading experts, and explore solutions to aged care challenges. I encourage you all to participate actively and fully embrace the opportunities this forum provides us. Together, we can ensure that our senior citizens receive the care, respect, and dignity they deserve. I extend my heartfelt thanks to the Australian DFAT for their participation and support, and to all the organizers, speakers, and participants. Thank you for joining us, whether in person or virtually, and I look forward to a productive and inspiring forum. Mabuhay again.
Thank you, Tricia, for that. Now we'll have the next speaker from Nepal.
Hello, good morning, distinguished guests and colleagues. Welcome to Asia Pacific Care Hub International Policy Forum. I'm Kavin Maliku. I'm representing APACH Foundation from Nepal and Australian Award Fellow. Today, we address the critical challenges of aged care in our region. This forum is a vital platform for sharing insight and fostering collaboration. Our joint effort in Asia Pacific region, clusters by partnership with Australia, can lead to significant improvement in aged care. By working together, we can develop effective strategies to ensure the well-being and dignity of our elderly population. I look forward to our discussion and partnership we will form to enhance aged care service across our region. We welcome you all with different stakeholders from Nepal. Thank you.
Thank you, Kabir, for that. Now we'll have from Malaysia.
Can you hear us? Hi. Yeah, we are actually on the other camera too. So I'm Morgan, and
hi, I'm Kejal.
yes, and We're all here from Malaysia. So we're at the Faculty of Medicine from the University of Malaya. There will be many more of us joining. These are the early birds who turned up on time. We are really looking forward and we've also got many from joining online as well, because many of them didn't want to brave the traffic or the parking challenges to come to Kuala Lumpur, to come to the University of Malaya. So we have been participating in the visit to Australia and also subsequent meetings from Malaysia as well. For Malaysia, we have unique issues with regards to aged care, as well as common issues with the other APAC partners. So we are looking forward to actually sharing notes about our challenges and coming up with common solutions, as well as learning new ideas from all our other country partners. Thank you.
Thank you, Morgan and Kejal. Thanks for that. Now we'll have from Philippines. Philippines is done. Indonesia. From Indonesia, are there any representatives online who would want to talk? So I think we have had the round of introductions. Now, since we have a couple of minutes left, I will request Ravi, can we have the AV of Ramaiah Medical College just to bridge the gap? And we'll be having these small AVs just as fillers before we move on to the first keynote at 9:30.
With total reverence, with bending my heart to him and seeing him, that light coming out, the golden light, the morning sun. And when I see that golden light falling from his face and to the body, and seeing the whole golden picture of him, I feel so great that this man, the man came, could do so much to me. And this makes me feel so small that can I be a part of that golden light where it can stay forever so that this light can be to the younger generation, to the younger people who are going to be born. And even for them, they can come and learn the wisdom. They can grow up as a full-fledged men of knowledge who can partake in this building of this nation.
So probably this is how it would run. Sorry for the abrupt stop of the AV, because we would want to have the time, and we have set most of our phones on the scheduled timers, so it gives me a 3 beep at 9:30 to say that, Nanda, it's time to start. So without much ado, I take this proud privilege to introduce the first keynote speaker, Dr. Uma Nambiar, CEO of Bagchi Parthasarathi Hospital, Indian Institute of Science, Bengaluru. It's my proud privilege and honor to welcome Madam. And I know she wants us to be ultra brief in introduction, but I deem it a necessity to say that with her more than 3.5 decades of experience in healthcare administration as an accomplished neurosurgeon, she blends both the worlds of medical administration, research, and a visionary in healthcare. In fact, when we were discussing the aged care, she narrated the first incident of starting the geriatric services almost 2 decades back, which was, I think, was too early. And today, as we stand here after almost 20 years since that experience, again, she's embarking on starting an MD Geriatrics program at the upcoming Indian Institute of Science Medical College. So this shows that it is a very important aspect of aging and life care that we are talking about. And I would request Dr. Uma to address the gathering with the first keynote. Thank you, ma'am.
Thank you.
They would also want you to take a rose.
Oh, no. I'll give it back to you. Okay, this is fine. Good morning, everyone. And Dr. Nandakumar and team, thank you for having me here. And I will hope that you've eaten up some 3 minutes of my time, so I was noticing. So let's talk about what are the challenges that we have in the aged care population in the region. So, in our lifetimes, we've seen how this has just slipped by. We all grew up with our grandparents and great-grandparents, and today we have families where the grandparents don't come visit, they don't stay together. And how over the last 50 to 60 years this has just happened, we have not noticed. And suddenly the problem is on us. There was a time when old age was not considered a problem, because they were a part of an ecosystem which was a joint family. In the family, the children got brought up, parents didn't know, grandparents got looked after, the kids didn't know. And everything went on smoothly. And suddenly, we are now faced with the reality that we are scared of old age. We don't know what we will do. The loneliness that actually hits people is far more than any other medical challenge that there is. And there is always a lurking fear as we age. With each birthday, you realize you're coming closer to a reality which you don't want to face. You start wondering, why am I living at all after a certain time? When you don't have anybody, the loneliness hits you so much. And if a person has lost a spouse, the feeling of loneliness and helplessness and not wanting to live anymore actually gets compounded much faster, and they suddenly start aging much faster. I've seen many of them saying, why not me? It's not something that when we are growing up, we don't think that we'll ever reach that stage. But that's the reality today. This is a no-brainer. All of us here in this auditorium know. Some are the price that we pay for having lived a very carefree and very happy life. So souvenirs that we carry, a heart disease here or a liver disease there, some more partying, some good liver disease. But anyway, these are all something that today, with better technology, with advanced healthcare, a lot of it can be monitored, a lot of it can be controlled, a lot of it can be delayed, and it is possible to live with many of these diseases. It's not such a challenge anymore. Only thing is that it comes at a cost. And that cost, who pays for it? In countries like India and in the neighboring region, there is no insurance cover to provide for care for many of these diseases in old age. And people have to pay out of pocket. Now, what does out of pocket mean for most of us? In the first 20 years, we were anyway not doing anything. We were living off our parents. In the next 20 years, we were trying to make a living. We didn't save anything because we were trying to get our act together. And in the next 20 years, we saved a part of what we earned. And we achieved, or we started living a quality of life which you couldn't live in 20% of what we saved. And after that 20 years, we are supposed to retire. So we have no more income coming, and whatever little we have saved, we are expecting to live the quality of life that we have left behind just one day before retirement, which is not possible. So the day a person is asked to retire or made to retire, and in either 60 or 62 or now sometimes 65, and for government doctors in India, 70 years of age, till today, you have no worries. And tomorrow when you retire, you have all the burden. And worse, your longevity is increasing because of all the advances in healthcare. So when a person was retiring at 60, when we became independent, our age expectancy was 62. So whatever you had saved for 20 years, you have to make it last for 2 years. Now, you have to make it last for God knows how many years, because people live easily for 70, 75, 80, 90, 95. And you don't know. You're literally every single day counting how much more your money can last you. So what happens? With this fixed amount of money, we are forced to choose a way of life that this money can afford us. You choose an elder care center, you put your deposit there, in the hope that if you live for the next 20 years, this elder care center will respect the terms and conditions on which you have joined, and that your money will last, and they will make sure that they take care of you as it has been promised. And first of all, in this day of turbulence in all the businesses, we don't even know whether that center will last. We don't know when we join. And the thing is, we have to put everything there and literally mortgage our lives to that center to take care of us. Are we doing it willingly? No. If we have a choice, would you do it? We probably won't. But why do we do it? Because today, as families are getting smaller, we feel that we don't want to become a burden on the society, on our family. That's a sentiment that's, especially in today's generation, and people are getting old now, that's a overarching sentiment. But given a chance, one wouldn't want to trade independence for anything. You would want to continue to live your free life. You don't want to live under somebody else's guidelines and regulations and a strict regime as to what time you have to get up in the morning and what you have to do, and not have any freedom at all. If there are illnesses, you can easily monitor your own health by some training. Under no condition would you want to actually put your own self-love or your own self-respect against giving yourself to elderly care center or any other care center or assisted living where you don't have any freedom and you're at somebody else's mercy. You don't want to be in a situation where you cannot respect yourself. So your own self-love, your need for independence is actually paramount in any human being. And I don't think that we choose these options because we want to. But today's situation is such that we don't have an alternative. We don't have another place to go. So I would like to really invite the technologists here that just like in acute care or in healthcare per se, barring acute care, we don't want to go to the hospital. We want to shift everything to home care. Aged care should actually start looking at it like this. Why should a person be asked to leave their home, their place of comfort, and go to a place, to an unknown caretaker, with unknown people, start life from scratch with completely not at your terms and conditions, and be forced to live like that? Can we not live in the same place with your same social life, with your own parties, with your own friends, with certain technological assistance to allow us to do that, where monitors, sensors placed in our house can allow our circle of care, and by circle of care, it could be your friends, your children, the nurse, can, without intruding in our lives, monitor what is happening and understand and take care. And I think that confidence, if somebody can give a person, I think that can retain the freedom that a person has. Well, another big problem. As we age, the society ages. What is the burden on the country? It is well known that, as I alluded to before, the day you retire, you stop earning, right? So you're living on this little pot of money that you have. State does not spend too much money on looking after the senior citizens. There is a limitation that the state has as well. However, if the number of elderly go up and the number of productive people in the country go down, the economic indices of the country are going to come spiraling down. And the economically weakest population in a country is technically the oldest people. Now, it is such a tragedy that we live our lives, at least between 40 to 60, really trying to live at the best quality of life that we can afford. And post that, we have to, when every day we start counting the monies that we can spend, our quality of life steadily deteriorates. And sometimes you won't even, today it is difficult to think how we would be 20 years down the line. We have no money, no savings, and living at the mercy of God knows who all, right? So that is something that we need to really see. Who has said that people should retire? It was okay to retire at 60 when people were living till 62. But when people are going to live till 90, 95, and nearly 99 or 100, why should you retire them at 60? So what is happening in the country? Productive life, 30 years. Non-productive, dependent, very, very, I would say, expensive life, because your healthcare expenses are far more than any other time in your life, for 30 years. Who's going to actually pay for this? How can we mitigate this? Self-employed person works till he can. He continues to have his self-respect and dignity and continues to earn till he can. Don't you think we should leverage the experience of old age? Why should we ask people to retire, is my question. Why should we not ask them to work, not as charity cases, which is what happens most of the time. Acha, theek hai, retired hai, let him come to the office for 2 hours, he'll come sit here, have a cup of coffee and go. No. Pay them for their worth. If they work for 1 hour, pay them for that 1 hour rate of work which they were charging when they were 60 years minus 1 day. We paid them. 60 years plus 1 day, they actually deserve the same rate. Till 75 or 80, till they can contribute the same to the community, they deserve the same respect, same dignity, same payment. Because it is not your lack of work or wanting to go to an office that kills you. It is when nobody respects you. And respect comes with the amount of money that you can earn. Your earning capacity actually is directly related to the amount of respect you have in the society. It's not just to provide for the elderly people. The experience that they have, the mentoring they can do for the youngsters is enormous advantage to us. And I think we should really look at that. And well, there are job portals for senior citizens in this country. So guys have started working on it, but I think it's too early, but there are things happening. And of course, as we get older, we must make sure that we don't only work, and old age is no bar to all the games that we want to play. We must continue all the song and dance that we want to indulge in. And of course, we need to swing it full, okay? Till the last innings, until the last day of our lives. With, of course, some protection that all the policymakers need to seriously think about. So if I was to close it with what conferences like this or what groups like APAC can do is to make sure that we can show the silver sunshine to the silver group. Thank you.
Thank you, ma'am, for that. And continuing with the keynote, Dr. Amrita Kansal will join, but we'll have Dr. Toshima from Nepal. We have a recorded video, and she's also present at the Nepal hub for questions subsequently. So just to introduce, Dr. Karki is a politician from Nepal, a surgeon by profession and member of Rashtriya Swatantra Party. She is the former Minister of Health Ministry of Nepal. For over a decade, Dr. Karki has been a leader in medical education and healthcare services, as well as being involved in civil rights issues. So we'll have a message record. She's live online, but the keynote is a recorded one, just to avoid technical glitches. And following the keynote, she will be interacting with us.
Namaste and a very good morning from Nepal. Myself, Dr. Toshima Karki, General Surgeon by profession, sitting member of Parliament of Nepal, former State Minister of Ministry of Health and Population of Nepal. It's an honor for me to attend this auspicious meet today. Thank you, APACH, for organizing this among the aged care experts from all over the world, usually representing the Asian region. It's an opportunity and also a very required and a sensitive topic. Actually, whenever I think about the elderly people, there's a story I heard in my childhood that always strikes my mind, the story of Doko. Doko in Nepal is a hand-woven basket made by bamboo. And that is usually used in rural areas where people carry materials like grasses, firewoods, logs, and even sick people to hospitals in the areas where ambulance is not available. Even the stretchers are not available, and the doko is itself used as the manual ambulance. So the story here begins like this. There was an old man who had a son, and he raised his son all alone, took care of his needs, education, and also got his son married to a very beautiful girl. The man started getting old. He started becoming responsibility for his son and the daughter-in-law. They had to take care of his clothing, feeding, and gradually old man started getting so old and sick that he got bedridden. He needed support for his daily chores. He was not able to move by himself, and he started becoming burden for his family. One night, the son of that old man, as he was lying on the bed, he saw a doko by his side, and he got an idea that he planned to take his father, the old man, on the doko up in the hill and push him down from the hill, so that the father would die and he would get relief from the bedridden life, and also the son and the daughter-in-law would be free from the burden of taking care of that old man. So, as per the idea he had, the very next morning, early in the morning, he carried his old father on his back in the doko and he went to the uphill. At the same time, he had a little son who was the grandson of the old man. He also followed the man who was carrying his father in the doko towards uphill. And as the son was trying to push his old father, down the hill with the doko, his little son interrupted him and said, "Father, please stop." And the father asked, "Why?" The little son said, "You can throw the grandfather down, but please do not throw the doko along with." The man turned back to his son and asked, "Why?" The little son innocently replied back, "As of now, my grandfather has grown so old that now you are pushing him down the hill. One day you would also grow old, and that time I will have to push you down the hill in the same manner, and in that time I will need this doko to carry you." As the man heard his little son saying this so innocently, this was the biggest realization for him. He felt guilty, he got sad, and he quickly took his old father back home and started taking care of the old man, who was his father actually. And they started living happily thereafter. Well, this is not only a story, but a reality that has depicted how the elderly population, how the older people have now been neglected and have been considered a burden in the family. And we have completely forgotten to realize that the youths of today are going to be the old citizen of tomorrow. Well, this is not only the problem limited to a country specifically. Actually, now this has been a global problem, a global issue where this kind of international sharings and discussions are required. The policymakers who sit and discuss on how the policies can protect the rights of citizens. How can older citizens can be made to feel loved, respected, and understood. Well, coming to the context of Nepal, there are around 2.97 million older people as per the census of 2021, which is in fact 38.2% increment in the population as compared to 2011 census. And this number is yet guaranteed to increase in the upcoming years because the data has shown that the independent population, the 16 to 40 years age population is around 40.3%, which holds the majority of the population share. And they are going to be old. They are going to grow old in upcoming 40 years. So ultimately, the older population percentage numbers, are going to increase in the upcoming years, and the burden is going to increase financially, economically, socially, in every aspect for any of the countries. I'd like to also bring into notice the, the data collected by World Health Organization, WHO itself, it mentions that due to the increased life expectancy, high inflation rate, family planning, decreased fertility rate, late age marriage, these all factors have made, the numbers of older population to increase and the younger than compared to the younger population. And, WHO states that by 2050, 1 in 5 of the population will be older people. And out of them, 80% of the population are going to reside, elder population are going to reside in lower and mid-income country. And one of the reasons for this is high migration rate of the youth population from the low and mid-income countries to high-income countries and developed countries. Furthermore, the current rate of migration in youths to the foreign countries have left the elderly population feel isolated, feel alone in countries like Nepal. And on top of this, 85% of the older population are residing in rural areas where they lack the facilities, to healthcare, nutrition, and also have increased risk of infectious and chronic diseases. Also, they suffer from mental and emotional weaknesses. And on top of them, the social security is almost, not appreciable. It's not that the government has not done anything. Actually, there are few efforts taken by the government. For example, we begin from the Constitution of Nepal 2015. The Article 41 has guaranteed protected the rights of senior citizens as fundamental right, and it mentions that senior citizens shall have the right to special protection and social security from the state. Yet that is not actually exercised, not actually made realized, and not actually into implementation. Because there are some of the provisions I would like to mention, like the government has been providing old age allowance monthly, that is Nepali rupees 4,000, which is nearly US dollar $30.5. That is since 2021, 22 BSL. Okay, that is since 2021-22, Nepali rupees 4,000, US dollar $30.5 monthly allowance, which the elderly people are using to take care of themselves, buy medicines or whatever. But actually, it's not enough. Even the government is providing pension, which is like the allowance for the public servants and the government officials. There are some allocated seats in transportation, like 2 seats for per vehicle reserved for the elderly people, and also there is 50% discount in transportation fare. There is subsidies for special healthcare, like cardiovascular conditions, chronic obstructive pulmonary disease and other disease conditions, usually for aged 75 years and more. Even there are some provisions for some of the centrally in district level and even in municipality level. There are some provisions of senior citizen welfare fund that has been used variously, for different supports. In Nepal, we have Senior Citizen Act since 2006, which has not been revised yet, but that is providing some of the social, economic, and human rights aspect for senior citizens, which actually considers family as a supporting unit in the society for senior citizen. And besides that, there are some of the religious and social groups that has been supporting the senior citizens in their own, with their own efforts, like in Nepal, actually not only in Nepal, I think it's in South Asian countries that we respect senior citizens. There are deep-rooted values, norms, where even in religious and cultural values, where we respect older citizens as God. We take blessings from them, and we are taught to consider them as the even the senior most citizen in the family is considered as one of the god in the family. So they are respected, they are worshipped, and they are taken care of. That is why family support system has been the major support system in taking care of the individuals in context of Nepal. Yet the rapid increase in the migration rate, the youths of Nepal are migrating abroad, and that has made the family support system weak for taking care of individuals, and that has led to the need of developing certain other kind of support system like religious and social support system, and that have been supporting to some extent. Besides that, there is one old age care home in that is run by government of Nepal. That is Pashupati Vriddhashram, and that in fact is the only government-run old age care home. Besides that, there are some of the care homes that has been run in private efforts by different social organizations and even in private efforts. So this is all provisions I think we have in Nepal that has been into my notice. And coming to some of the limitations in context of Nepal regarding the care of elderly population. Well, the fact is, the health budget is very low itself in government of Nepal. WHO has clearly mentioned that health should get, around 10% of the total budget of the country. But in context of Nepal, we have only around 5% of budget allocated for entire health system. And out of them, the budget allocated for elderly citizen care is almost negligible. So that has to be increased actually. And we do not have trained manpower for taking care of geriatric population, like dedicated geriatric care team who are trained, who are, efficient enough. We have the know-how of taking care of elderly population. We really lack on that. Even in hospitals, there are certain few of the government, almost only one government hospital has geriatric ward, and sorry to say that it is almost not working right now because of the lack of infrastructures and manpower. Rehabilitative services also, there are almost very few, and one of the major reason behind this is we lack enough data, research, investigations, and to realization of needs and know-how of the elderly care. The allowance is itself very low to take care. $35 a month is almost nothing in the very high inflation rate of today. Youths, one of the things that has to be considered is we are not being able to retain our youths in the country itself, and that is why the elderly population are feeling helpless, feeling frustrated, and even they are feeling like they have no one to take care of, feeling isolated and demoralized. I think that is one of the things a country like Nepal has to consider to retain. The policies should focus on retaining the youths in the country. One of the irony I would like to share is, the higher level policy makers in Nepal are elderly population, and if you see the Parliament of Nepal, most of them are almost elderly people, even in the Parliament of Nepal. And the amazing thing that really amazes the youth leaders like us is, despite of having lots of majority of politicians in Nepal and parliamentary in Nepal who are themselves elderly people, they are not working for enough of the policy level provisions for elderly care in Nepal. I don't know why. Neither they are thinking of themselves nor about the further upcoming generation. So what next? What would be the way forward? Not only in Nepal, but the country like Nepal now should focus on taking care of elderly population, because we should never forget. Once again, I'd like to highlight on the youth of today are the elderly population of tomorrow. So we should focus on developing the proper provisions for elderly qualitative aging for the people. Qualitative researchers are required. More of the investments should be there in the elderly population care. In context of Nepal, we really need to revise the Senior Citizens Act, which was in 2006, and now we are in 2024. So the technology, the needs, the basic needs, the inflation rate has been changed drastically, and we are working in the same previous provision that really needs the homework. the mindset has to be changed. In fact, we were brought up in a very, good upbringing where we were taught to respect the senior citizens. But what happened is, with the span of, with the development of science and technology and sophisticated life and employment and everything, the youth really forgot the upbringings they were taught about when they were very, when they were a very young children, So once again, please do not forget the story of Dogo. Today's youth are the old people of tomorrow. Taking care of elderly people is not only about doing the task, but about making them feel loved, understood, and respected. I am very much open to discussion, queries, questions, and sharings of the wonderful policies that have been practicing in the countries where the elderly care provisions have been doing very nice. Please do share those provisions. I'm very much open to questions and queries. Before I leave, I would like to give a note. Dear youths, constructing qualitative aged care system for elderly people of today is in fact a preparation for quality aging of ourselves for tomorrow. I repeat, constructing qualitative aged care system for elderly people of today is in fact a preparation for quality aging of ourselves for tomorrow. Thank you and namaste.
Thank you, Dr. Karki, for that wonderful talk. If you're online, ma'am, can we have your video on, or can you unmute and speak, ma'am? Dr. Karki?
Yes. Namaste from Nepal.
It's a wonderful thing, and fortunately the Morse law has not caught up, and there have been no technology glitches so far. I will hold the entire wooden panel. So, ma'am, you would want to say a couple of things since you're live, and then we will have Dr. Amrita with her keynote. Over to Karki.
I didn't. Can you?
I want to add something apart from the recorded message that we just heard.
Okay, namaste for everyone. Actually, I really wanted to present the entire presentation, the keynote speech, the live only, but I was asked to have some recordings so that there won't be the internet disturbances around the world from everyone who has been watching right now. I would like to once again, ask everyone to please do not forget the story of Dogo. I think you all have, that is something new for the people who have not actually encountered the Dogo, which is also used for, air ambulance. It is also used as manual ambulance in Nepal, in very remote areas. And one thing I'd like to mention here is we youths happen to forget that we are going to grow old as well. So that is something that should not be forgotten. The elderly people, actually, they do not need favor. They need love. They need to be respected. And they need to be made felt that how difficultly, how they had struggled during their lifetime to bring up their children. And that contribution should be acknowledged. That contribution should be respected. So we all youths should never forget that they are the ones who are, actually the contributors making us to the stage where we have been today. So I would like to tell everyone that the construction of the good aged care system for today is preparation for ourselves.
Thank you.
When we grow old, we have very quality aging preparations for ourselves. Thank you.
Thank you, Dr. Karki, for that. That's wonderful. Thanks a lot. Moving on, We have Dr. Amrita Kansal, Technical Officer, WHO CRO. Dr. Kansal is a distinguished public health expert affiliated with World Health Organization's Southeast Asia Regional Office, CRO, in Delhi. With a comprehensive background in public health policy and management, Dr. Kansal plays a pivotal role in advancing healthcare initiatives across the region. Notably, she has made significant contributions in maternal and child health, healthcare needs of the elderly population as well in recent times. Dr. Kansal's advocacy and strategic interventions aim to improve access to quality healthcare services for older adults, emphasizing preventive care, chronic disease management, and social inclusions. Through her leadership and collaborative efforts, she fosters innovative approaches to enhance the well-being and quality of life for elderly individuals in Southeast Asia region. Without much ado, I present Dr. Amrita Kansal.
It's okay, fine. Okay, thanks. Thank you very much, Dr. Nandakumar, for a very kind introduction. And thank you very much, all the experts, professionals, faculty members, fellows, researchers, and international delegates. I'm really happy to be here physically at this forum, and my utmost gratitude to Ramaiah Medical College to invite me to speak here. And I would like to also congratulate all the fellows. I came to know that this is through the Australian government fellowship program, and it was done for aged care in capacity building for aged care in the Asia Pacific region, and which is very, very much needed. And I would like to congratulate all the fellows, and I look forward that they contribute in improving the health and care of older people in the region. So with all this, and I really heard my previous speaker from Nepal. So I have served in Nepal for almost 4 years. And yes, I know political and health systems of Nepal significantly, I would say. So I was there from 2019 till 2023. So till last year I was there. So it was a good experience, and everything she mentioned. In fact, towards the end, I got the chance to contribute to the healthy aging part as well. And it was very good to see that Nepal has all the policies, legislation in place, and they could do it in the recent 2 to 3 years only, because the constitution came into place in 2015, and after that they started making all the policies and legislation, and they have the provision of pension and everything. However, this is not enough. We know it has to be very comprehensive. It has to address all the areas of health care, as well as the broader system so that older people are the part of society. They are socially connected, and they are not left behind when we talk about universal health coverage, because there is no health if we leave behind these almost 15 to 20% in the globe, as well as in the Asia Pacific region. Also, many countries are now approaching to be the aged society, which is going to be the 20%. So coming to my presentation, I would like to highlight a few facts which has been already, in fact, highlighted by previous speakers. So I'll go very quickly. So we all know that longer lives, people are living longer, and which is in a way humanity's greatest achievement of our health system, of our generation, I would say, and it should be celebrated. We were running after increasing the life expectancy for so many years, and now we are struggling. We are facing this as a challenge. However, it should not be. So it is increasing everywhere. This is a life expectancy at birth. Over last 20 years, we can see it has increased almost by 6 years. And by 1990, if I take it, it has increased almost 8 years everywhere. So, but how are they living? How these older people are living? Are they healthy? Are they happy? So are they able to do what they want to do? Are they able to be what they want to be? So the data says, if we see the life expectancy versus healthy life expectancy. So if we take the difference, this will give us the number of years which older people are expected to spend without having good health. And this number of years is increasing over the last 20-30 years, and we can see, if we see life expectancy and healthy life expectancy at birth, the number has increased from 7.3 to 8.3 in males, and from 9.7 to 11 years in females. So 11 years females are expected to live in poor health in the later half of their age. And if we take life expectancy and healthy life expectancy at the age of 60 years, which is more scientific, it has also increased significantly. So they are not spending these extra years of life in good health. And we all agree, we all believe with this all sustainable development goal commitments, as well as the universal health coverage ideology or strategy, that everybody, all the older people everywhere should enjoy good health and well-being in their later life as well. And this is, again, we all know that population aging is an ongoing phenomenon, and now the Asian countries, Asia Pacific countries, are also catching up. And here I would like to emphasize the velocity, the pace of population aging. So European world, Western world, they had enough time when the population increased from 10% to 20%. When we say that society is aged, they took almost 70, 80 years. So they had the time to, build up their systems, health systems, to take care of these healthy people, older people. However, if we see the Asian countries, there are a few Asian countries, including India. So India, if I emphasize, only 35 years we will take to increase the population of older people, reaching from 10% to 20%. 35 years only, we will be double. So hardly any time, and we all know that we are developing countries, and most of the countries in Asia Pacific region are developing. So it's rather, I would say, a challenge, and it's a task for the government. So if we see the longevity and healthier life, so longer life and healthy life, the difference we noticed, and how we can address this, so whether we have opportunities or not. So a significant opportunity I would like to highlight is that the United Nations has declared this decade, current decade, to 2021 to 2030, as the decade for healthy aging. And this is really a wonderful framework, and this calls stakeholders across the sectors to work together to improve the lives of older people. So this is basically to galvanize the collaboration between stakeholders and partners, and the framework is all about doing business differently, and it talks about 4 action areas, 4 enablers, and keeping the older people at the center of the framework, because they are the drivers for the change. And this is a little bit, about this 4 areas. Action areas, first is changing how we think, feel, and act towards age and aging. Second is ensure that communities foster the abilities of older people, means age-friendly environment. And then third is deliver integrated care and primary health services responsive to older people. And fourth is the long-term care for older people who need it. it should be available. And the enablers to bring this big change or improvement in all these 4 areas are listening to the voices and engagement of older people, their families, caregivers, and communities. Then nurturing the leadership and capacity building for integrated action, connecting stakeholders around the globe, and strengthening the capacity for data, research, and innovation in countries. So this United Nations Decade for Healthy Aging is being monitored well, and the task has been given to accomplish this task of monitoring and evaluation of the decade. There is a technical advisory group for monitoring of healthy aging with partners and stakeholders and experts from all over. And the baseline was done in 2020, and recently in 2023 the process evaluation was done, and this report, the entire report, is available at WHO website. And I would like to request to have attention to on this slide, which says that all 10 national indicators which were agreed to kind of monitor the decade progress have shown progress in countries. So the methodology has been given in details in the report. However, these 10 indicators, because we are comparing from 2020 to 2023, so only all countries provided data, almost 140 countries provided data. However, the comparison has been done some 100 plus countries for each indicator, because we had to take only those countries for each indicator which provided data for both times, only then the comparison is possible. And we see that there has been progress despite all the challenges the world has gone through during these 3 years, including COVID pandemic. So government paid attention, they had legislation policies, and here I would like to further highlight that there has been more than 20% increase in 4 indicators, which are 4, 5, 6, 7. So 4 is that government had the policies and legislations for age-based discrimination. So it increased by 20%. Then policies which provides access to assistive device to older people have also improved by 20%. Then government having policies and program for age-friendly environment also improved by 20%. And the government's commitment in terms of policy and program for comprehensive assessment of older people has also increased by 20%. So this is a very significant improvement in a way. But this is not enough, because what happened? If we see there's another slide, because we collected, this is lots of data, and I would like whoever the researchers, fellows, and who are working for older people, please go through this report. This is very recent, almost 60 pages report, but it gives you a sense what is happening around the world and what needs to be focused. And this is like 2023 report, and another report will come in 2026. So every 3 years we will be coming up with process evaluation report. So this is I think a very good report, and I think countries may consider to kind of refer this. So if we see this graph, we saw that the indicators are showing improvement. However, this graph, which is about availability of resources to implement the UN Decade of Healthy Aging by action areas. So I told you that there are 4 areas: combating ageism, age-friendly environment, integrated care for older people, and long-term care. So if we see the resources, and this colors is showing the no resource, very limited resource, adequate resource, and substantial resource. So the green part is adequate or substantial resource, and only 1/3 of the countries. So this is because only 2023 data. So the number of countries included are 133 or 134, and it shows that only 1/3 of the countries said that they have enough resources or adequate resources to fully deliver on the UN decade. So this is the scenario. They have policies. Policies are there in 70% of countries, 80% of the countries, but resources, hardly 1/3 of the countries. Then if we see that the countries which don't have any resources, that is almost 10%. So this dark pink on the left hand side, you can see is 10%, 9%, 7.5%. So 10% countries don't have any resource to put it to make sure that the older people are having good life in any of the areas, action areas. And if we see all these resources, and yes, and yeah, so this is something like very alarming. However, we need to read in between words, and we need to go through the report to understand even better, like where the countries are, where the countries stand in terms of their commitments, political commitment, as well as resources availability. So this is a scenario, and the baseline is that we need investment. Nothing is possible without the resources and investment by the government and making the efforts to foster healthy aging. So I'm not sure if you are interested, I can tell you the key findings under each action areas of the decade. So first action area, this is combating ageism. And the main key findings are that data says that 83% of countries had national legislation on discrimination by age, which is up from 60% in 2020. Only 3 years did the people consider, because I think COVID also, it was a blessing in disguise, I would say. Government started focusing on older people. They came up with the policies and legislation to improve the lives of the older people, I believe. So it was up. However, if we see the commitment, only 22% of the countries reported having resources to implement activities in this area. So the policies without resources has no meaning. Then coming to the another learning is that the policies, law, education, and intergenerational interventions are effective in combating ageism. Older people are taking actions to combat ageism everywhere, including campaigning for change. But evidence is needed. These kind of things are happening in countries, by civil society and others. These are best practices, but these needs to be evaluated to determine whether these activities are effective, scalable, and sustainable. And then older people are sometimes, it was also found that they are themselves reluctant to engage in activities related to ageism because of their own or social perceptions of words such as aging, older, old. So they are also reluctant to be the part of the policy making or the discussions which are happening all over. Action area 2, and please, this is the baseline of the decade, that older people should be at the center of the planning. We should not assume that older people want this. We should ask what they need. Because every country, the cultural, socio-economic scenario is different, their needs are different. And you cannot imagine that the kind of services which you are providing in European world will be significant for the Asian world. So we have to ask them, what do they really want? And this report also gives you the case stories where the older people were asked, what do they really want? There are case stories from India when the women were asked, like, what do they want in their old age? And everybody said that they want a good, healthy life. They want health was their priority. So, but it might be different in other countries. So they should be asked, and the program areas, the program should be prioritized as per their voices. Coming to the communities foster the abilities, this is age-friendly environment. 77% of the countries reported having a national program to support activities of the WHO Global Network for Age-Friendly Cities and Communities in 2022, which is up from 52% in 2020. So this is a global network, which basically this is a platform, but I need to have more time to discuss about it. If you are interested, you can discuss with me during the lunchtime or break time, if you are interested. So this is a global network age-friendly environment. 77% countries have policies, but commitment in terms of resources is only 26% countries. Initiatives, another learning is that initiatives often focus on a particular element, and strategic oversight and coordination are necessary to bring the elements together. As we saw, we visited the age-friendly, whatever you say, the assisted living facilities yesterday. So a few people, they were focusing that they are getting their food. It was a kind of a good room where they are getting all kind of comforts, and they were provided food, all the meals, and their within, without making any effort. But what about other services? What about social connection? What about so many other things? Whether they are being asked, what do they want? Or do they don't want? So something like we have good example. They were very good example. But these they have to be these. There should be an evaluation. There should be a standard. There should be a framework. There should be parameters. How we measure whether these are good or bad or worse. So I'll finish in another 5 minutes. Initiatives often focus on a particular element. I said this, and then age-friendly environment must be inclusive of and work for groups of older people who are often marginalized. So we've never discussed even about those people who are further vulnerable among the older people, like people with disabilities, older LGBTQ plus people, and people with cognitive impairment, and humanitarian context. So these things we are not even thinking about it in our world, in Asian world. 3 also the same. This is integrated care of older people. 71% countries they have policies. 27% have resources. WHO's integrated care for older people, which is now a kind of an it has been quite well taken by most of the countries, and it is a key resource to provide integrated care and primary healthcare services. Widespread interest has been shown by the countries, and they are using it for building their human resource capacity. And but we always recommend, and it came through the findings that local adaptation should be there to organize and monitor the care. And there are initiatives which are addressing older people's comprehensive health and care needs and neglected issues. Action area 4 is very significant in terms of long-term care, but it's very poor. Commitment is there in many countries, but only 34% are having resources. And informal unpaid carers have insufficient support. Only 16% of low-income countries provide such support. So these pensions, these unpaid carers. So just to conclude that despite progress, accelerated action is required. We need more investment. We need more political commitment to healthy aging, especially in lower middle income country, where 80% of older people will live by 2050. And we need more meaningful engagement of older people in decisions that matter to them. With this, I'm just thankful for your patient listening. And if you have any questions, please let me know. I'm sorry I took a little more time, but maybe I was being slow because I had some headache. So maybe I was speaking very slow. It was a very slow place, but thank you very much.
Thank you, Dr. Amrita, for that. And God has been kind today because we are having this across 5 countries with multiple participants online, offline, and a constellation of speakers coming in, and fortunately we are running on time. So without much ado, I thank the keynote speakers for the day, Dr. Uma Nambiar from IISc, Dr. Karki from Nepal, Member of Parliament, and Dr. Amrita Kansal, the representative from World Health Organization. So in the next minute or two, we will start the inaugural of the program, which is across the different countries. And I request Dr. Ameya to be the master of ceremony for the inaugural.
Good morning, all. Thank you, sir. Moving on, after the first session of the conference, I would now kindly request everyone to rise for the Ramaya anthem.
सकलांतर्यामी हरिणी चाला भजिन्तुं ज्ञानं विज्ञानं च भक्तिसहितम् ज्ञान विज्ञान विद्या विनय भूषण ईरामय्य समूह संस्थान ज्ञान विज्ञान विद्या विनय भूषण ईरामय्य समूह संस्थान तारे निहारिते यादने ईमान के जय वेन्नुव ई संस्थान के ದ್ರಷ್ಟಾರರು ಕಟ್ಟಿದ ಕನಸಿನ ಸಾಮ್ರಾಜ್ಯವಿದು ದೀಪದೊಳು ಪ್ರದೀಪಗಳ ಬೆಳಗುವ ಶ್ರದ್ಧಾ ಸ್ಥಾನವಿದು ಅರಿವಿನ ದಿಗಂತರಾಚೆಗೆ ಜಿಗಿಯುವ ಸಂಪನ್ಮೂಲವಿದು ಗೃಹ ಗೃಹದಲ್ಲಿ ಗೃಹ ನಿರ್ಮಾಣಕ್ಕೆ ತಂತ್ರಜ್ಞಾನದ ಸೋಪಾನವಿದು ಅಮಿತ ಜ್ಞಾನಕ್ಕೆ ಸಾಧನ ಕ್ಷೇತ್ರವಿದು ಪ್ರತಿಭೆಯ ಸಾಧನೆ ಮಾಡಲು ಸ್ಫೂರ್ತಿಯ ಕೇಂದ್ರವಿದು ಅಜ್ಞಾನದ ಕತ್ತಲೆ ನೀಗುವ ಸುಜ್ಞಾನದ ಸೂರ್ಯನ ರಶ್ಮಿದು ಜಗದೋದ್ಧಾರದ ಹೊಂಗನಸಲು ಹೊತ್ತಿದ ಅರಿವಿನ ತಾಣವಿದು ಅರಿವಿನ ಅಳತೆಯು ಬೆಳಕನ್ನು ಚೆಲ್ಲಿದೆ ಅಸಂಖ್ಯಾತ ಕಿರಣಗಳು ಎಲ್ಲೆಡೆ ಹೊರಹೊಮ್ಮಿವೆ ಜಯವೆನ್ನುವ ಈ ಸಂಸ್ಥಾನಕ್ಕೆ
Thank you, ladies and gentlemen. I would now humbly request Dr. Shalini C. Nui, Principal and Dean, Ramaya Medical College, to come on stage and say a few words.
Morning. Would you like to invite the dignitaries on the dais? Probably you could call them on the dais.
I would humbly request all the dignitaries to kindly grace the occasion by having your esteemed presence on the dais, please. Dr. O.P. Karbanda, Dr. M.R. Jairam sir, Sri M.R. Srinivas Murthy sir,
Dr. Raj Singh Shekhawat.
Dr. Raj Singh Shekhawat.
Dr. Angie.
Dr. M.G. Shafi. And Dr. Shalini Singh.
Thank you, Dr. Aditya. Wishing you all a very pleasant morning. It is wonderful to see such an eminent group of people here with a single-minded aim of making the lives of our elders better and to discuss policies which will help them to live a comfortable and useful life. I feel privileged to welcome our Honorable Chief Executive, Shri M.R. Srinivasamurthy, IAS, whose positive and wonderful words always make us value them. I warmly welcome Dr. O.P. Kharbanda, who is our Pro Vice Chancellor of Health Sciences, Ramaiah University of Applied Sciences. Our Chairman, Honorable Dr. M.R. Jairam, will join us shortly, but he has sent his best wishes. Similarly, our Vice Chancellor, Dr. Kuldeep Kumar Raina, has not been able to join us now, but he too sends us his greetings for the success of this program. Dr. Randeep D., the Commissioner of Health in Bangalore, who is also the Director, State Mission Director for Ayushman Bharat Digital Mission, unfortunately could not join us, and he sends us his greetings, and he has also assured us of the commitment of the government towards the care of the elderly. I heartily welcome Dr. Angie Shafi, who is the Dean of Business in Flinders University, Australia. I welcome Dr. Raj Shekhawat too from Flinders University, Australia. I warmly welcome all our esteemed faculty, guests, and colleagues to this program. Just to say a few words about this program, the developing world is going grey, and by 2050, it is said that at least 50% of the population is going to be over the age of 60. The developing world, there's a seismic demographic shift of the elderly to the developing world. We can see that by the end of another 25 to 50 years, we will have more than 80% of the elderly in the world living in developing countries, and more so in Asia. Of these, a majority will be females because, as you know, the biological strength of the female gender is higher than that of the male gender. Sadly, I just read the authors of a letter in The Lancet, which is an esteemed journal in medicine, have mentioned that age is considered always in the negative terms. The elderly are termed as a burden to society and to resources. All too often, we hear about the atrocities on the elderly. The much publicized dispute between the founder and the heir of the Raymond Group of Industries is as important to us as the obscure Manjunatha or Jayanti who lives in any remote Indian village. How can one ignore the value of the older person? How can we ignore the value of their knowledge? How can we ignore their experience and hence the value as a teacher? How can we ignore them as conflict resolvers and those that bind families together? This is what we would like to bring out and discuss during this forum. Increase in longevity and decline in the joint family system and the breakdown of the social fabric has led to loneliness and neglect of the elderly in many countries, including India. The government of India, therefore, has started taking measures to see that we support our elderly. And therefore, the government of India's national policy on older persons was brought out 25 years ago in 1999. And later, the Maintenance and Welfare of Parents and Senior Citizen Act in 2007, the National Policy for Senior Citizens in 2011. And these provide the legal framework for supporting the needs of seniors. But as Dr. Anita Khasla was mentioning in the previous talk, policies are just not enough. We need to take action. We need to implement them, which is not happening in many countries. So therefore, this conference brings together a diverse group of experts, policymakers, administrators, stakeholders like elderly and the community. We hope that you bring with you, I'm sure each of you bring with you a unique perspective and invaluable expertise which will help us explore the needs of the elderly in our society. We hope to have developed a clearer roadmap by the end of this conference, which will be supportive and inclusive to the elderly in our community. Together, we can forge pathways to a future where every elderly individual feels valued, supported, and cherished. Thank you very much. Have a wonderful two-day program.
Thank you so much, ma'am, for those wonderful words. I would like to request the dignitaries for this lamp lighting ceremony. It's a solemn occasion to signify the enlightenment of knowledge and wisdom.
Shubham kurutvam kalyanam arogyam dhanasampada. Shubham kurutvam kalyanam arogyam dhanasampada. Shatrubuddhi vinashaya Deepajyotir namostute. Deepajyotir namostute. Deepajyotir parabrahma. Deepajyotir janardanaha. Deepajyotir parabrahma. Deepajyotir janardanaha. Deepo bhartu me papam. Sandhya deepa namostute. O deepa brahma rupasvam. Jyotisha prabhuravyayah. O deepa brahma rupasvam. Jyotisha prabhuravyayah. Arogyam dehi putrasya. Matim swachhangi me sada. Ravirasam samarabhya. Yavat suryodayo bhavet. Ravirasam samarabhya. Yavat suryodayo bhavet. Yasya dishte griheti.
Thank you, respected dignitaries. I would now like to call upon Dr. Madan Balasubramaniam, Senior Lecturer, Health and Aged Care Management, Business Research Lead, Flinders University, for a brief introduction to Asia Pacific Aged Care Hub and Department of Foreign Affairs and Trade.
Respected chief guests, guests of honor, esteemed keynote speakers, expert panel members, staff and students joining here at this beautiful campus of Ramaiah University, India, and our satellite hubs in Philippines at the University of Santo Tomas and at the University of Malaya at Malaysia, Ask Foundation at Nepal, and Australia at Flinders University, and those across the Asia-Pacific region, including Bangladesh, Indonesia, and all those globally joining online. And also to our well-wishers, our supporters, our friends for improving aged care across the Asia-Pacific region. On behalf of the project team at Flinders University and the Aged Care Research and Industry Innovation Australia, Arya, we extend a warm welcome and thank you for actually welcoming us here and hosting this wonderful event here at Ramaiah University. Aged care is an issue of emerging significance here in the Asia-Pacific region, and several countries in the region, including India, Philippines, Indonesia, Malaysia, Australia, all experiencing higher life expectancy, lower fertility rates, and lower mortality rates. Nearly 60% of the world population over 60 years of age reside here in the Asia-Pacific region, which amounts to nearly 630 million people. This population is projected to reach 1.3 billion by 2050. With countries in the Asia-Pacific region aging faster than any other region of this world, as Dr. Amrita actually pointed out in terms of the velocity of aging today, this demographic transition and the challenges associated with aging have grown to be of utmost social, political, healthcare, and economic significance. Across the 56 countries in the Asia-Pacific region, there are varying levels of social and economic levels of progress. Over the last 2 decades, China, India, Indonesia, Philippines, Thailand, and Vietnam have consistently outperformed other emerging markets in the world economy. In addition to the fast-paced economic growth in the region, Asia-Pacific countries share a very rich cultural diversity. In many cultures, particularly those in the Indian subcontinent, China and South Asia, there is a deeply ingrained tradition of venerating older adults, and with the care for aged parents being seen as a sacred duty as bestowed by the divine. Nevertheless, these societies are facing increased pressure for globalization and westernization of care and reshaping conventional approaches towards older adult care. Aged care, again, is an issue that could not be solved by one disciplinary perspective alone. It requires a multidisciplinary approach, and experts from health, law, business, social work, and science need to work together. This Asia-Pacific Aged Care Hub emerges from this transdisciplinary thinking as a core philosophy where we bring our expertise from our experts from multiple disciplines to address key challenges facing the aged or aging population in order to offer a wide-ranging impact when it comes to research, when it comes to academic outcomes, when it comes to industry, and when it comes to social outcomes. So the Asia Pacific Aged Care Hub is a capacity building initiative which was started by the Flinders University and ARIA, the Aged Care Research and Industry Innovation Australia, and it's supported by funding from the Australian Government Department of Foreign Affairs and Trade through the Esteemed Australia Awards Fellowship Program. So APAC is an effort to enhance aged care across the Asia Pacific region. This program aims to facilitate collaboration among individuals in the aged care sector and fostering and sharing of insights and best practices at both the systemic and the grassroots level, and also to accelerate academic, research, industry, and policy outcomes. So 13 leading organizations across the 7 countries are part of APAC. Ask Foundation, Nepal, Jagannath University, Bangladesh, Manipal Academy of Higher Education, Hyderabad Central University, BC Shivana Foundation, Feel It Good Aged Care Homes, Indian Dental Association, Sharavati Dental College and Hospital, University of Malaya, Malaysia, University of Santo Tomas, Philippines, University of Sebikas Maret, Indonesia, and of course, Flinders University, ARIA, and our host, MS Ramaiah University. So the APAC team acknowledged the support received from DFAT, the Australian Awards Fellowship, through the Department of Foreign Affairs and Trade. And we're also extremely grateful to Ramaiah University for hosting us this International Policy Forum here in this beautiful city of Bangalore. And we're very grateful to the leadership at Ramaiah University. Thank you very much, sir. And I would also like to acknowledge Professor Nandakumar for his leadership in organizing this event, and we're very grateful for him and his team. So thank you all for being with us here today, and we look forward for the interactions and collaborations for the next 2 days.
We're going to continue the Australian this
So I would like to also introduce our Australian host from Flinders University who are joining us online. So they have sent the welcome videos in order to avoid any technical difficulties. Can we first actually have Professor Vincent Balloon, who is the Pro Vice Chancellor of Research at Flinders University, please?
Good morning. My name is Vincent Billon. I'm the Pro Vice Chancellor for Research, Performance and Impact at Flinders University in Adelaide, Australia. Thank you for giving me the opportunity to briefly present Flinders University at this Asia-Pacific Aged Care International Policy Forum. Aged care is a top priority in our university, where we are building transdisciplinary research across all our colleges. This is an area that we want to develop further across the Asia-Pacific region. So we look very much forward to hearing the outcome of this policy forum and see how further collaborations can be established between our university and other key players in that space in the Asia-Pacific region. I look very much forward to hearing the outcome of this conference, of this forum, and also to establish a further collaboration in the future. Wishing you a very successful forum. Thank you very much.
Can I now actually invite Mr. Bill Damascius, who's the Director of International Partnerships. Bill has actually graciously accepted to be online with us today. And if Bill is there online, can you please put Bill on the spotlight, please? Search for Bill Damascius.
You can announce for Bill, so you can
Yep. So I think maybe we would go to the other videos first, and we'll come back to Bill as soon as he joins us. So now we would have Professor Adila McMurray, who is the Dean of Research at the College of Business, Government and Law, to welcome us here at this gathering.
Good afternoon, ladies and gentlemen, and welcome to the Asia Pacific Aged Care Hub International Policy Forum. It's with immense pleasure that I have been invited to welcome this remarkable gathering of extraordinary thought leaders. This event stands as a testament to your collective dedication, passion, and vision for aged care across global boundaries. As we convene here today, we embark on a journey of exploration, innovation, and collaboration. Whether you are a seasoned expert in your field or an eager newcomer, this event promises to be a platform where ideas converge, knowledge amplifies, and connections flourish. Over the next few days, you will engage in thought-provoking discussions and delve into cutting-edge research and practices and witness awe-inspiring demonstrations and case studies. Through keynote speeches, panel discussions, workshops, and networking sessions, you will not only enrich your understanding, but also forge enduring relationships that transcend geographical boundaries and disciplinary silos. At the heart of this event lies a shared commitment to aged care and health. It's a commitment that drives us to push the boundaries of what is possible, to challenge conventional wisdom, and to harness the power of collective intellect to address the pressing challenges of our time. In closing, I extend my deepest gratitude to all of our sponsors and partners, speakers, and volunteers who have worked tirelessly to make this event a reality. Your unwavering support and dedication are the foundation upon which this event stands and paves the way for the more inclusive and sustainable future. In addition, the College of Business, Government and Law here at Flinders University which is home to the Australian Industrial Transformation Institute and the Factory of the Future. It works with SMEs, the Jeff Bleich Centre for Democracy and Disruptive Technologies, and the Centre for Social Impact all extend warm invitations for transdisciplinary collaboration. I invite each one of you to seize this opportunity to learn, to connect, and to inspire, and to emerge from this event not just as participants, but as catalysts and leaders for positive change in our communities and beyond. Thank you, and let this journey continue.
I would now like to play Professor Sue Gordon, who was with us in the first leg of the program in Australia when all the fellows visited us at the Aged Care Research and Industry Innovation Australia, followed by Mr. Ruben Jacob, who is the CEO of the Aged Care Research and Industry Australia.
Hello everybody, my name is Sue Gordon. I'm a professor at Flinders University and I'm currently the Research Director at ARIA, Aged Care Research and Industry Innovation Australia. I've been on this journey with ARIA for many years. I was one of the founders who developed the proposal for government to have something like ARIA. This involved a consultation nationally about what the aged care sector needed to be able to put evidence into practice and to actually grow through the use of technology. I've been in this role for 2-3 years now, and part of my responsibility is to oversee the $13 million worth of grants that we have funded across the nation. I'm really pleased to be part of this forum, and I'm sorry I can't be there in person. Thank you.
I would now humbly request Associate Professor Angie Shafei, Dean Flinders Business, to say a few words, please.
Thanks.
Yes, please. It is my honor to welcome our chairman, Honorable Chairman Dr. M.R. Jairam, to this forum. He has made time to be with us despite his busy schedule. Thank you for coming, sir. Thank you.
Thank you.
Good morning, everyone, and swagat. I hope I pronounced that correctly. As the Dean of Business at Flinders University, it's an honor to be part of the forum today. I would like to begin by acknowledging Ramaya University and the leadership team, and thank you for your generous hospitality and warm welcome. It's a pleasure and a privilege to be with you here today on behalf of Flinders University. As a globally focused and locally engaged university, we are making a difference through innovative research, excellence in teaching and learning, and providing exceptional experience and support for our students. Our footprint extends across Australia and internationally, as we are ranked in the top 2% of universities worldwide with over 26,000 students, 2,300 staff, and over 500 postgraduate and undergraduate and research degrees. In an era of disruptive change, Flinders University is growing its international reputation as a leader in research and innovator in contemporary education and a source of enterprising graduates equipped to change the world. We're internationally engaged with over 100 partner institutions across 33 countries with long-standing meaningful partnerships, and we're deeply honored to be collaborating with Ramaya University in this inaugural collaboration across the Asia-Pacific hub. Flinders Business is in a unique position to be the home of the health and aged care management programs with deep synergies across medicine, nursing, public and allied health, with a vision to embrace innovative knowledge and practice to tackle the challenges of our time, and a strategic focus on health, social impact and technology as we prepare the workforce of the future. With deep synergies between the visions of our two esteemed organizations, we look forward to a long partnership, with this being just the forefront and the first initiative that we are working on together. It's a pleasure to be hosting this inaugural collaboration across 6 countries, As many of our esteemed guest speakers have already talked about, the myriad of challenges across global aging populations. This exchange of knowledge and expertise from some of the brightest minds across 6 countries could not come at a more opportune time. With the global population rapidly aging, this really prompts us to focused efforts on positive pathways towards healthy aging. Across Asia and the Pacific region, 1 in 7 people are aged 60 years and over. With the projections by 2050, 1 in 4 people will fall within this aged group. While improvements in public health and medical advances are contributing to increasing life expectancy, and as our speakers have contributed that this has been our vision for a very long time in health and aged care, our rapidly aging population does present profound challenges and complex consequences for our overburdened health systems, with also our older adults often presenting with a myriad of complex chronic conditions. So this aging will have significant impact on how cities and communities are built and organized, and this amazing thought leadership in the room will be contributing towards discussing many topics and hearing from esteemed experts on models of care, digital technologies, innovations, and much more, aiming to build capacity to enhance, share insights for best healthy aging, contributing to better outcomes and improved quality of care across the Asia Pacific. Thank you very much for joining us today, and we look forward to very interesting conversations and deep thoughts across the next few days. Thank you.
Thank you, Professor Angie. I would now like to call upon Associate Professor Andreas Sebula, the research lead of the Australian Industrial Transformation Institute at the College of Business, Government and Law.
Thank you very much, and namaste, and thank you for the invitation and the opportunity to be here. I want to say a few words about the Australian Industrial Transformation Institute, which is a very long name. Was mentioned earlier. We are part of the College of Business at Flinders University, but we're different. We're different because we're on a separate campus to start with. And while we are a group of researchers who do largely labor market related research, we are also a factory. And I mean a factory because we actually have a site where we assist businesses, small businesses usually, in developing product innovations. And part of that is what we call a digital innovation lab. It's a separate site where we have a lot of digital technology for businesses to experiment with and design new products and new processes. Now, you may ask, what has that to do with APAC and with aged care? It has quite a lot to do with it, and could possibly have even more to do with it in the future. It already has a link to the kind of work that APAC is doing, as we are on the research side exploring the labor market for in the healthcare and aged care sector. Workforce planning is a important aspect of our work. We have done and continue to do work about the employment opportunities of older workers, so anyone over 55, etc., usually at risk of exiting the labor market early, but there are increasingly opportunities and means and efforts made to retain and perhaps reallocate labor force to stay in the labor market for longer. And on the factory side, I should also mention the other aspect we're doing was looking at migration, because obviously in Australia, as you may be aware, migrants are a key factor of the aged care and the healthcare workforce. So a large part of our work is to explore how the migrant workforce is integrated into the labor market, but also society. And interestingly enough, those who work in the aged care and healthcare sector integrating much better than other sectors. So there are lessons to learn how the aged care and the healthcare sector integrates an international workforce into the service industry that are provided there. The other point is our factory. I haven't got any pictures, but if you get a chance to search for factoryofthefuture.com.au, you will see a little video about what's happening on our side. There currently construction has started on a new development of a factory where we have even more opportunity to integrate and assist small businesses in developing new products and new processes. And a great opportunity for that is, in fact, in the health and aged care sector. We're aiming to, as this new development takes off, explore new markets in that area to see how we can assist not just businesses, but we heard earlier today, aging in place in the home, how the technologies can be applied in real life. So all these are things that are being explored at the minute in our center. And yeah, I'm here to learn and get ideas, get inspiration from what everyone else has been doing and is planning to do in the near future in that area. Thank you very much.
Thank you, Professor Andreas. Now, on behalf of the Ramaiah family, I would now like to call upon Professor O.P. Kharbandasa, the Pro Vice Chancellor, Health Sciences, to us to address the audience.
Good morning to you all, respected Chancellor and Chairman, Sir, Dr. Amar Jaram, our Chief Executive, dignitaries on the dais, off the dais, our visiting delegation from Australia, Flinders University from Adelaide, and particularly I'd like to mention Professor Shekhawat, Dr. Angie, and Madan, and of course our Dean, for bringing everything together into this hub at Ramaiah. It started a few months ago, rather, about a year now, I think, when I received an email from Madan, and this, we never knew that we will have so much of energy and enthusiasm to get together to create this hub. So I congratulate all of you who have put in their efforts to bring it to this level. Aged care or care of the aged people has always been a challenge. And in our culture, what is so-called our Sanatan culture, we always considered parents like gods. And we had been kind of trying to do that, but urbanization, need to travel overseas, and many more reasons, and also access to the care has become more difficult with time, as our aged population proportions have also increased. The spectrum of diseases have also changed. Earlier people, when they used to die, most of them, they die as healthy people. It was a natural death. But now the deaths are happening due to many other reasons. And in particular, the mental health has become very challenging in old age. I'm just narrating you one experience from my real life, which happened only a year ago. My son, he's in UK and his classmate is in US. And he calls me to tell me that his grandmother and mother lives alone in Bangalore. And can you, I moved here in Bangalore, can you help them with their medical help? I said, sure. So the grandmother was sick, and the mother was sick. So mother is hospitalized, but grandmother is being looked after by the GP and she's okay. And she cannot travel. She is a doctor, and she has a duty, and she can only travel after 7 days or 8 days, and by the time she reaches here, they may be very sick. So can you help them? So I tried to help them as much as I could. There were 4 in the family: mother, grandmother, a dog, and the daughter. So she arrives, she goes directly to the hospital, and when she reaches the hospital, the mother is grasping for her last breath. She was lucky she could meet her. And when she could arrange her to be transported to her home, they found that the grandmother is also no more. Now they have a dog, and she has to go back to duty to US in a week's time. Now she asked, is there any agency who can look after to make the last rites? And yes, now when we explore, we find that there are agencies, there are, what you're talking about, labor, there are people who help to do that. And when that has been done, but now who will take care of the dog? There's another family member, it's like a family member. So the neighbors were requested, and they happily adopted the dog. And my son visited a few months ago here in Bangalore, and she got a phone call, can you visit the dog and send the video and pictures of that dog? This is the reality of life. Now, but that doesn't happen always. This is one of the rare events, but it does happen. Now the issue is that when we meet about aged care and we create a hub, we have to create more spikes. We have to more people with us. And it is not just the availability of resources. It is also the how we handle those resources for the aged people. Because access to care is difficult for the aged people. So a few years ago, I think, maybe 3 years ago, it is just before COVID. So there is a forum in France who has digitized everything. So there are cameras, there are audio sensors who are monitoring the movements of elderly people sitting there in a control room. So their temperature, what temperature is in the room, and all those kind of things. So maybe the next revolution, what you're talking about, digital revolution and technology would have everything of that kind. But one thing I'm sure, what we are going to miss is human touch. So there is no substitute for human touch. We can advance the technology, we can create everything, but we must also find ways to connect with our own family so that we can come the real touch. I think I have just created an environment for further discussions without taking much time. I like to thank our leadership at Ramaiya to have allowed and encouraged us to create this, use this facility, use this institution. And also I thank the Flinders University leadership to have helped us to do this. My good wishes for the success of this program. Thank you.
Thank you, sir, for those wonderful words. We now conclude the inauguration ceremony by the vote of thanks by Dr. B.S. Nandakumar, Professor Community Medicine, Associate Dean Research, to us.
I have no idea.
What else is happening?
They call me.
I've been told by C sir and Chairman sir.
They call me, I go up.
Thank you, sir.
I don't know anything about it.
Actually, I asked Leela, madam. Sir, with your permission, I will ask 91 years old, Dr. Leela. Okay. Thank you, everyone. A program of this magnitude is just not possible with any individual or single institution. So we are having it across multiple countries, across different time zones, and more than 300 people, because I was just tracking the number of people online, offline, and when we started, we wanted 50 people for the event. We are having 373 people across, both on YouTube platform. Live program is being on LinkedIn, YouTube, and multiple things, and digital is truly the real thing now. So I express my gratitude to the senior leadership at Ramaiya College and the Ramaiya University, our Chancellor, the CE, and the list has 43 names. And I'm sure I will miss someone who is most important. So in that context, we have had a very good support at the university and with the Flinders senior leadership and management as well, who have worked tirelessly. As I was mentioning, more than 7,300 email communications have gone. 6,000 WhatsApp messages have gone, and back and forth we have had multiple iterations, interactions, online meetings, and preparation for this truly remarkable event that is going to happen in the next 2 days. So without taking much time, we are running on time, fortunately. I express my gratitude to the entire team who are here, virtual, and also contributing in remote places for making this program a huge success. And I would like to emphasize that this is just a beginning. What we have started across the Asia Pacific network, in all the countries, there will be white papers, there will be policy papers, there will be publications, and more than anything of these academic pursuits, we would want to see it translated to the ground level so that the elderly will have a better life and a better quality of life for them to enjoy. So I once again thank the Almighty for this opportunity, and I thank everyone who is part of this program. Thanks a lot. Thank you very much. For the participants, we have a 15-minute break. And even for online participants, there is a bio break for 15 minutes. The tea and coffee is arranged outside on the left side. And we have the washrooms on either side for ladies and gentlemen. I would request you to please assemble back sharp at 11:30. I know it's very short time, 15 minutes, back in this auditorium for the session, panel session, which will be conducted by Dr. Madan. We can have a good photograph as well with the senior leadership. Some of you who would want to come out, we can have a this.
check call.
Yeah, okay, sure. Yeah, sure. Hello?
Leela.
Hello, yeah, sure. Sure, okay.
I'll check this.
Yes.
I do email ID. I Gmail.
Yeah, I'm supposed to be part of that.
Sure, that's perfect, yeah. So, do we have all the people? Yeah? Will slide for the next session? It won't be there.
It should come, it should pop up, so just give it some time. So,
Will a slide will come for the session? Thank you.
so we are going to be standing, Raj, so you can stand.
Okay. We don't need 5 chairs because 3 of these people will be virtual.
Oh, we virtual, okay.
Only 2 people. So you can maybe they can just sit down. You can sit as well. Like you could be on the one corner, I could be on the other corner, and we can just sort of have a conversation.
Sure. If you want to stand, if you want to sit down is also fine.
Because I'm just trying to think that it'll be easy for the camera to capture everything. If you're standing too, like moving around, it might be a little bit tricky.
Sure. Otherwise, be stationary standing at one place, but otherwise, I think you can sit down and you could do that. So yeah, that sounds like.
Otherwise, it'll be 1 hour of standing.
Yeah, I mean, we're already 10 minutes late, right? So I think you can.
I can sit here.
Okay,
so I'm happy to sit here. So
I'll be
what's the name of the lady who is doing the?
Silvani, he's going to be starting, and he's going to be inviting us. So we can just be sitting down.
Yeah. So
can you just talk about the panelists? I'm
yeah, I'm all right. That's fine, right? You know, I feel. Yeah, after last time, you said you called it cat, right?
Yeah, he's waiting. Jyoti. We are just running 10 minutes late, so yes.
Good morning, everyone. And let me start by saying I'm really sorry that we are 10 minutes late. The online or satellite hub people were all waiting there, and I think we need to start the first panel. which is the innovative model of care and health workforce solutions for aged care. And to chair this panel, I would like to welcome Professor Raj Shekhawat. He is an internationally recognized award-winning academician, mentor, TEDx speaker, and a scientist. He has a PhD in clinical audiology from the University of Auckland, which complements his outstanding international reputation for research and findings which employ brain stimulation, sound therapies, and hearing aids for tinnitus management. Professor Shekhawat has diverse work experience spanning 4 continents and 6 countries, touching a plethora of cultural communities with his impeccable knowledge along the way. I really warmly welcome you to chair this session, sir.
Thank you, Triveni.
And the co-chair for this session is Dr. Madan Balasubramanian. He's a senior lecturer in health management and business research lead at Flinders University, Australia. Dr. Madan has a passion for aligning the health workforce with population needs. He advocates for the shift towards multi-professional care models, recognized with prestigious fellowships and awards. He has authored numerous peer-reviewed articles and contributed significantly to national surveys and health workforce research. His recent research has had a profound impact on various health workforce issues cited by international bodies such as the WHO and contributing to global guidance on health practitioner regulations. His work on integrated care and health workforce solutions has influenced education, regulation, and practice in healthcare, advocating for expanded scope and skill diversity among the health professionals. We want to welcome you. And now I'd like to invite the panel members for this discussion, Dr. Rima Nadika, Dr. Usha Manjuna, Dr. Darren Burwick will be joining online. He's already joined. We are really sorry that we are running a little bit late. Mr. Lee Martin and Dr. Radha S. Murthy. Please come on the dais and speak.
Please come here. Please, ma'am. Please have a seat. Thank you. Thank you. All right. Thank you so much. Well, good morning to everyone. We all know that we have got almost over 350 delegates from 5 countries across the various places, either in person here or watching us online. So namaste and a very warm welcome to everybody who is watching us online or people who are right here. This is going to be a very, very, very interesting panel discussion session. We have a wonderful title about innovative models of care and workforce solutions for aged care. And we have 5 outstanding panelists with us today. 2 of them are online, 3 of us are right here. So I'm going to be very briefly introducing them. And in the interest of time, we will make sure that we finish this session in the next 45 minutes or so that we are back on the exact same time, all right? So let me just very quickly introduce 3 of the panelists, and my co-chair, Madan, will be introducing the other 2. So we have with us Dr. Radha S. Murthy, and Dr. Radha is from Dementia India Alliance, and she's the president, which is amazing. So thank you for being with us. We have Dr. Darren Burback. He's joining us online. Darren is the CEO of Rest Haven Aged Care Center in Adelaide. Hi, Darren. Hope you're well. Lovely to see you. We also have Mr. Lee Martin, who's the CEO of Tanunda Aged Care Homes, Barossa Valley in South Australia. Hi, Lee. Hope you're well. You can hear us well? Yes. Fantastic. Now over to you, Madan, to introduce the other 2 panelists.
Thank you, Raj. So it's my pleasure to actually introduce Professor Usha Manjunath, who is the director of the Indian Institute of Health Management and Research, Bangalore. Professor Usha ma'am has been working in healthcare for a considerable period of time and has expertise in a range of issues, but I actually found it quite fascinating on her work when it comes to skill mix and scope of practice. And I've read your papers as well as ma'am. Thank you for joining us. And I would also like to introduce Dr. Rima Nadik from the KITES Aged Care. And Dr. Reema Nadik is the co-founder and the CEO of the Kite Senior Care in India. Thank you so much for joining with us, Dr. Reema.
Thank you, Madan. Now, everybody who is watching us online or in person, especially in person here, those of you who have ever seen a young baby, please raise your hands. Practically everybody, isn't it? The people who are watching us online as well, I would really like you to imagine a young baby. And there's this big saying that it takes a village to raise a child, right? We all have heard that. It takes a village to raise a child. Now, nobody talks after that. Imagine the same child, when the child grows into an older person. What about that scenario? It indeed takes actually multiple villages to ensure that the same child once becomes an older person to be looked after really, really well to ensure they have an amazing quality of life. So what we will be doing today is, with our expert panelists here, we'll be touching on various aspects of aged care innovation and also trying to see how we can make this session really, really useful to have some takeaway messages. So, my very first question for you, Dr. Radha, is dementia care and aged care. There are lots of parallels between the two. Aging and dementia are kind of linked as well. So could you please share some of your experiences in terms of similarities and common challenges between those two? And the mic is right there in front of you. Thank you.
Thank you so much for this. And before I tell you about the Dementia India Alliance, I would also like to say that I'm managing trustee for Nightingale's Medical Trust, who we have been in aged care for nearly about 28 years and set up models of care for both aging as well as dementia. So that's why my experience comes here as to how we have gone through for the past 28 years, how the whole scenario is changing. Now, we have already heard about the senior citizens numbers growing, and 2050, how it's going to be more. So you've heard about all these things. Somehow aging, I understand, is people have understood it through the years. And there is some sort of what you call as things which are in place. But dementia is just an emerging one for India, because when I started the home care in 1996, when I used to go to the families and see, I could not pick up dementia at that time in 1996. But after about 5 years, I realized that there is something wrong, and the awareness was there. And we have already set up many of these people, many of you all have corporates, set up many things for the older people, like retirement homes, old age homes and all that. But when we set up something called the dementia, the residential care, the home care, and also daycare centers, I found what the difference is. It is a general pattern for aging. It's a general one. But here is a focused, what you call, care that you have to do. Focused care in the sense because of lack of communication, which is very difficult. Communication, very difficult. You have to change the environment, because just whatever you have in old age homes is just not enough. You need more signages, you need more help, and also trained people in dementia is still lacking. Aging somehow comes naturally to you because families have taken care of them. But here, when it comes to dementia, people don't realize. They think it's just part of aging, and probably he's gone mentally. This was the thing. The other thing what I noticed is people stigma.
Yes.
What differentiated between the aging thing and the thing was the stigma which is attached, and people find it difficult even to come and express how the thing is. Now, when you come to support system, old age homes, respite care can easily take care about the whole thing. But when it comes to dementia, we need memory screening, we need a comprehensive more number of cares, and people have to understand this particular subject. So I'll quickly say why there's a difference is stigma, cost of care. is more, because it's not that one person sits, understands, communicates. You have to have a special person to teach. Or if you cannot manage at home, you need two people to be sitting there to look after. The burnout of the caregivers is much more when it comes to dementia and not in aging. The other thing is we have some policy in place for aging, but when it comes to dementia, there is no policy as yet. So we still have to this. Also, you notice that managing aging has been a good procedure, but dementia is just evolving.
Sure.
So there's a lot to learn more. So these are the few differences which I felt was so difficult is to manage a person with dementia in the elder homes.
So true. Thank you so much for raising those important points. Things about stigma, awareness, things about training the trainers, things about offering personalized care, things about need for policies. All of those things are really, really crucial. We'll lead that discussion further. Over to you, Madan.
I think what ma'am was actually talking about in terms of the models of care for dementia really leads very well to our next question to Professor Manjunath. Ma'am, in terms of your experience, are there any innovative models of care that you have actually encountered or you feel that have been successful here in India? And also, have you actually seen any health workforce challenges in terms of these models?
Thank you. I will presently not limit to dementia care. So what we will, first of all, look at how, part of some of the government programs have also helped, because if we really look at the people who are aged, 71% of them live in rural areas, and approximately about 30% are in the urban areas. So there are a lot of different innovative ways, models, care that is given. So I will also kind of restrict to a little bit more on healthcare. Now the government program on health and wellness centers, the Ayushman Arogya Bharat, has given us a good model where there is going to be for care for non-communicable diseases, and which is very, very prevalent, and that is also very prevalent in the rural sector. So we were earlier thinking that if it's diabetes or hypertension is a disease of the people in the urban areas who are affluent and very people who have a lot of money and things like that, and it's not anymore that. There's a lot of people who require care. So in our experience, when we have worked with the communities and at the level of health and wellness center, so now there are about 1.5 lakh sub-centers which are converted into health and wellness center, and then there is a health, community health officer, then there is a health inspector, then there is ASHA who will help at the village level. So these are community which is really doing comprehensive care. So right now, there is a program for NCPDS, and then that really now takes care of screening, and then the medications and others are given at the center. So if we see, this has impacted quite a bit in terms of how rural population are able to access healthcare. And but then the solution is not perfect yet, but it has made a lot of difference to rural population where they are able to really go have the medication, continuity of care, and then there is a continuous linkages from the sub-center to the primary health center, the medical officer, and to further referral to the other centers. But definitely, if I will look at the manpower and the training challenges, the program continues to have this. As we all know, the requirements of experts and specialists still suffers in the system that we really look at. So therefore, these are certain challenges, and also the community needs. So if we really look at, it is not just the healthcare need, because there's a social part, there's a financial part, and the economic part as well. And so this has to be comprehensively addressed. And skilling of the people continues to be a major challenge. But at this level of the rural care, for the communicable diseases and non-communicable diseases at the center has really given a better access. But then to improve availability of doctors and others, they have also taken up telemedicine at the stage. But then, the success of that has to really improve. The models probably should also be looking more and more at PPP models, where people have experts, people have the swing, and maybe they can work with these government programs, and so there are definite innovations that have been really given. So this is one of the successful ones where India is now looking at not just elderly, but then from the 30 plus are being screened, are being really treated, and this has shown certain improvements in how it is delivered at that point, and it is now also connected with the digital health part of it, where there are portals, where there are data is collected, the continuity of care is really happening. So there's an NCT portal, there is a ABDM, which is the Ayushman Bharat Digital Mission, also takes it. So from that perspective, yes, training and various other things have to continuously go ahead and connect with it.
Sure. That's fascinating. I mean, hearing that almost 70% people living in rural, regional, remote areas, which definitely brings us very important point of accessibility of services and accessibility of care, which leads us really beautifully into technological innovations. So Darren, this is where I'm going to bring you in. So as a technology expert, we know that technology is changing at a very rapid pace. We also know the fact that multiple countries around the globe, a lot of concentration is there in the rural, remote areas. So Darren, if you could just unpack your viewpoints in terms of how technology can play an important role in this space, that would be wonderful. Over to you.
Thank you. Good morning. Yes, we at Resthaven, we have 12 residential care homes. 3 of those are in regional areas, and we have almost 3,000 home care packages which we deliver across South Australia. And recently, like any technology, you need to reinvest in it. So we've had a digital transformation program that's invested $20 million into those services. Like anything, you've had technology before, you've got to reinvest in your things like ERP, HR, and all those other systems. But what you really want to do is the services at the bedside or at the client's home. So we've recently rolled out our community services module, and that's enabled people to access these systems in people's homes. And we've done that through smartphones. So people will have the care plans, the progress notes, and the like in people's homes, and then they can see their rosters and see who they're going to see next. Communication is so important when it comes to our community services staff, because they're geographically remote. So we have to be able to find new ways in which to communicate with them. Phone can be effective, but we're finding MS Teams is a really good way to do that. We can get messages that would otherwise not be available to our staff. They can connect in ways that they're more familiar with. And increasingly, people are wanting to communicate in more digital forms, whether that be through Messenger or whether it be through text. So we're sort of moving our systems more to that way.
Thank you so much for that, Darren. Darren, there's this whole concept of digital divide. So if you could just personally share some of your experiences in terms of how hard or how challenging or how easy it has been for you as a CEO to incorporate technology in the space of healthcare.
Yeah, we're seeing, we've traditionally in Australia had quite an older cohort in terms of our staff. So the people delivering care have been often women in their 50s. And over the last little while, we've seen a change in that with the increased staff from overseas. The age of our workforce is dropping dramatically. But that training for people who are delivering the care can be challenging. So it's not just the digital divide in terms of our staff, but also the residents and clients. So we're implementing systems into our homes, which is very unfamiliar for an older person who may not have grown up with that type of technology. But similarly, some of our staff are the same. I remember when we first implemented clinical systems, we actually had to teach some of the staff how to double-click a mouse because they'd always been at the bedside. They'd been providing care. It was quite unfamiliar to them. But being able to do that has meant that they can they do the care plans, they do the progress notes on technology. We reduce that administration burden for them so that they can provide more care.
Absolutely. Thank you so much for that, Darren. Can I also share very quickly with all of you my experience? Last month, I went to a restaurant for a meal, and when we did our order, I saw this robot coming with all our orders in, and I found it very fascinating, especially the younger kids. They quite liked it. So I think the implementation and the translation of technology to facilitate and to make a difference is really, really important. And at this point, Lee Martin, I would like to bring you in the discussion. So would you like to share some of the technological innovations you are using at your facilities, and what is your experience and what are the experience of the end users have been at the care facility? If you just can unpack those, that would be wonderful.
Yeah, thank you for the introduction. And like Darren, I run an aged care facility in a rural sector of South Australia. And technology certainly is one of our biggest and more expensive nightmares in aged care. Some years ago, I actually did a review of what my staff were actually doing in the way of tasks during the day. And I found out that my staff were actually pushing various trolleys about 9,000 kilometres a year. And not only that, but they were suffering injuries of all sorts through pushing trolleys, etc. And so I decided I'd introduce robots. So over the last couple of years, I now have 10 operational robots. I have what's known as truck robots that lift and carry any sort of trolley. So the robots deliver food or linen or clothes around our facility. Then I have cleaning robots that can sweep and vacuum or wash and vacuum many metres of corridor floors and so on. I have delivery robots that, as you pointed out, it's the same sort of robot you have in a restaurant. Our cafe robot delivers meals to all around the facility. And then I have comfort robots. So I have Paro the seal that is very cute and cuddly and reacts more to the voice and touch of people who may be suffering dementia or in distress. And then I have coming in the next week or so a robot that's called Abby. And Abby is a humanoid robot. It can sing and dance. It can do Tai Chi. It can speak 90 languages.
Wow.
And through facial recognition, recognise you today, answer all your questions today, and then come back tomorrow and continue the discussion. So it can, in actual fact, start forming relationships, which is what I'm hoping to do in the future. So I've actually found that by the introduction of robotics, I've been able to reduce tasks normally done by humans and give the time back to the staff to spend more quality time with their residents. And the robots do tasks that are safer, more efficiently than what humans could ever do.
Now, Lee Martin, thank you so much for that insightful sharing. Can I also say that in my mind, I used to think that Barossa Valley is just famous for amazing wineries and wines, but looks like your care facility seems like a fascinating place as well. So I can't wait to visit there as well sometime soon. Can I also share another viewpoint that often people sometimes think that, oh, technology is coming to get our jobs. Technology is going to come in and replace us. Robots are going to come and take our jobs. So very briefly, I will first ask Darren to comment on that, and then I'll come back to you, Lee Martin. So what are your thoughts in terms of this whole perception about the space for technology as well as workforce?
I think aged care has to be about the person to the person, and it's so important. And we at Resthaven invested a lot of time and effort in our people and in developing and growing what they can do, particularly in a leadership sense. So we've had a Resthaven leadership program that we've rolled out to our top leaders. 50 people have gone through that. We've also rolled out a team talent showcase, which is like an experiential day where people from all across the organisation come together. A bit of fun. It's a bit of a survivor-like situation where they're challenged with different leadership the types of things they'd experience normally in a day. They go home very tired after that. Lots of colour, lots of fun. And we're doing a lot of work in the cultural intelligence space because we have over 100 different nationalities represented at Resthaven. We're an incredibly diverse workforce. And with that diversity comes our strength. We get all the benefit of all of the knowledge from all of the people from all over the world. A third of our staff, actually more than 40%, are born out of Australia, but in the Asia Pacific region. So we have 650 people from Nepal alone, 450 people from India, and many from Sri Lanka, Philippines, Malaysia, and they form that really rich tapestry, which is our workforce. So being able to find ways and pathways for them is really important. So we now have representation. We have a quarter of our managers are from the region, and a third of our staff are in our middle managers group. So it's a really important investment. I would pick up on Dr. Karki's point, though. It's that ethical migration. How can we make sure that we can give back to their home countries and find ways to reinvest in aged care across the globe?
Sure. Lee Martin, you want to quickly jump in there in terms of are robots coming to take away the jobs of the workforce people, or they are just there to help and optimize it? What are your thoughts?
Robots optimize human workforce. Just to put it into context, in 2022, Australia had a census where it was measured of how many were in the workforce. There were over 14 million people in our workforce working, but 500,000 of those people working were in actual fact not able to work due to injuries suffered at work. And their major injuries were through back, shoulders, necks and elbows. Now, if you want to injure yourself, just push a trolley 9,000 kilometres. And so what I say is that robots are here to assist us, not to take over our jobs. I've been able to, over the last couple of years, save up to about 5 full-time equivalent in time from my staff that I've given back to care staff to be able to look after their residents in a more meaningful way. There's no need for a human to push a trolley from point A to point B and then bring it back again. When a machine can do it just as well. And it's like mopping floors. You don't need people mopping floors when a machine can do it at 2 o'clock in the morning and have all the floors nice and clean for when staff and residents come in the morning. So it's all about having the right robots, doing the right tasks and involving the residents and the staff in the journey of implementing robots into the aged care environment.
Thank you, Lee Martin. Over to you.
Thank you so much, Lee and Darren. It is very good to actually hear about the experience in Australia, and we all enjoyed our visit to Barossa Valley Tanuda Aged Care Home, and thank you so much for hosting us. And we have our memories are still fresh in our mind, looking at the robots carrying food for us at the dining room. So thank you so much. So now, I think this actually takes us really very well into our next question in terms of strategies. And I would like to actually ask Dr. Rima, in terms of what strategies have been successful in terms of taking workforce and also technology in terms of the population who are actually in need, the aged care population in need?
Great. Thank you so much for having me here. It's wonderful to be here, and especially with ma'am who has paved the path for senior care in India. Thank you, ma'am. Very, very relevant question, but I think as far as I'm concerned, my personal opinion is we are too early to answer that question because yet we are just evolving. Senior care in India is at a very nascent stage. Developed countries like Australia, New Zealand, UK, US, etc. have been doing this for the past 30, 40 years. And, in India, culturally, as you said, village raises a kid. That's what was happening in India also. Culturally, we had to make that difference. And we are seeing the difference happening now. People accepting that, yes, elders need a different kind of care environment is happening now. The variety of care that we have to provide elders ranges from healthy aging to acute care to chronic disease management, hospice, palliative, till the time they hit the grave. So there's a variety of care that we need to provide at different times with the different interventions that we have to try. Certain interventions are person-based, certain interventions are technology-based, and I was very glad to hear that how technology is also playing a part, because technology in future has to be the enabler. It will help in scalability, it will help impacting a large number of people. We have to have it. It can't be ignored. We have to have it included in our strategy and the planning that we do. Also touching upon the point which Dr. Uma also made about PPP models, because there are different socioeconomic strata that we have to reach out to. Rural, remote places where PPP will work very well, in semi-urban and urban areas where there can be a combination of people intervention as well as technology interventions. Then there have to be spaces that need to be created for elders for different kind of interventions. The kind of model that we work on is out of hospital chronic care management for elders. That is one part of it where care takes over the treatment. Treatment is not the first priority, but the care takes over because we have to focus on the quality of care and the quality of life, enhancing the quality of life. So here more takes over are the physiotherapies, the different kind of therapies, the food, and the care element. Another very important part where technology can help us is the medicine compliance. It is one of the factors that compromises the clinical outcomes. How is it that we can use technology? There are new technologies coming up like pill box. There's technologies in the US that are very, very convenient to ensure that people, elders, whether they are suffering from dementia or not, or initial stages of dementia, are able to, and we are able to track their compliance to the medications, ensuring that their clinical outcomes are better. So yes, combination of people, because older people, we cannot stay away from personal touch and feel. 100% human beings have to be involved. And as Mr. Martin also said that, wherever the warmth is required, wherever the human intervention is required, we should not be replacing human people, but repetitive, automated jobs can be replaced by technology, and wherever technology can help us would be the way to go.
Friends, sure.
In technology, at least the care models which can be useful is, one is what we've tried is online screening. Sure. Online screening for dementia, which we felt that because of the stigma attached or people cannot come there, this online thing which we had done from Dementia India Alliance helps us to reach much more people all over wherever they are. So that is one part of it which is very helpful. And the other one is when you say the distant training or distant, it has helped in technology, especially when we have about what you call as care homes far away, and how do we manage from here? So this sort of a thing, we tried it in Kolar, and we saw that the cost of care comes down using this technology about nearly 40%, which is a big sizable thing. So for care, and what I meant is training, and for prevention. Now we also have something called active aging, which can be online.
Yes.
So these are the things which do for care, which technology have still developed, and still going on.
Wonderful.
So adding to Raymond's.
Yeah. What I'm going to do is, in the interest of time, we have got the last 15 minutes, and in this last 15 minutes, we're going to do some rapid fire. So what we'll do is, all our panelists will almost have 30 seconds to share their topmost idea which is coming to their mind, okay? So the question is, what is the primary workforce challenge and the training need in the sector? So over to you, Darren. What do you think is the primary workforce challenge and the training need in the sector?
I think it's adding to what people have said. It's about providing the best dementia care. It's about palliative care. It's about incontinence. It's bringing up our people so that they can deliver the best quality care. And that's about investing in our people.
Thank you. Lee Martin?
It's all about workforce. It's all about recruitment of the right people into the right positions. And we need to do more in encouraging people to come and work out in the rural and remote sort of areas, particularly throughout Australia.
Good point. Over to you, ma'am.
Yeah, in terms of really, because the workforce also are stressed, working with the aged, I think, providing them support, also like creating a lot of aspects of soft skills, their ability to really communicate well,
yes.
That becomes the most important.
Beautiful. Over to you.
I think we need to increase the number of specializations in the geriatric care. Geriatric physicians, geriatric nursing, geriatric physiotherapy. There's a lot of, in our experience, we have felt that, every kind of physician or a nurse or a therapist cannot fix it for the geriatric population. They require a specialized approach and protocols that need to be thought about. So, specializations in geriatric.
Thank you. So the question is, what is the primary workforce challenge and training need in the sector according to you?
I didn't get it.
Primary workforce challenge and the training need in the sector.
I said earlier that difficulty comes again when looking after people with dementia. Sure. When it comes to normal aging, I think it's easier to sort of train the workforce. And then there's no career path for the workforce which is there. Sure. So that is the reason why we are not able to get more number of people to look after. The workforce is dwindling. Suppose we show them a career path and then something else, we add on like a diploma or some sort of a thing. I'm sure the attrition will be down. It will be much more better for the caregiving and all that. Sure. So my sincere thing is, how do we change the way we call them as caregivers, the workforce for the looking after aging? Suppose we add on something more value, probably we may succeed.
Wonderful. I think you very beautifully mentioned about how people need to work together. So which also brings to this very important second phase, which is all about interdisciplinary collaboration. Looking after aged care population requires strong communication, collaboration across diverse set of health sector and health sector providers. So my question is, what do you think, how significant is interdisciplinary collaboration and what can we do to facilitate it? So I'm going to go again back to you, Darren. What do you think, how important interdisciplinary collaboration is and what can be done to facilitate it?
Yeah, I think it's critical, actually, in terms of working together as a sector rather than working in competition. And it was actually at an ARIA conference, one of the presenters talked about co-opetition, and I think it's a very powerful term. It's where can we share and work together in areas where it really doesn't matter. We're actually not in competition, we're doing it together. I think there's lots of opportunity for that.
Wonderful. Lee Martin, over to you.
I was at a meeting with some general practitioner doctors last night, and we were talking about how, as an aged care service and a GP service and the general hospital service could work together to ensure that be it residents or patients can move in between all places where health is provided. Technology will help that. But it also comes down to acceptance by governments at government to ensure that there is the appropriate funding to ensure that residents are receiving care in the right places.
Thank you. How important do you think is interdisciplinary collaboration, and what can be done to facilitate it?
At the outset, yes, it is very, very critical. Looking at the way aged care is done in India, a lot of the aged care that is provided is in the unorganized sector.
Sure.
So what happens there is whether it is the skill sets, whether it is the provisioning of care or the standardization, how do we really do it? So there is different levels of care that are given. Different professionals are used, maybe different levels of professionals. So if I may have an occupational therapist, I may have a physiotherapist, but for the aged care, how do we really standardize those? So that is where I think the interdisciplinary would also very much help.
Sure.
And I think bringing the people in the unorganized sector in, there's a lot of opportunity to really bring them for skilling and training and across the sector. It's
Sure.
Not just one discipline, but across.
Over to you. Yep.
I think it's a very, very valid question because senior care, as we talk about toddlers, there are different kind of children. And old age is a second childhood. So as teachers are teaching the kids, each kid requires a different kind of attention and intervention. Similarly, as we look at elders, they require different kind of attention and intervention. And in the developed countries, you must have heard the concept called CCRC, the Continued Care Retirement Communities, where it is in one huge acreage, you have active aging, then you have rehabilitation, you have hospice, palliative, and dementia care. So I will talk about Indian scenario. I think that's a very beautiful model to have, but in Indian scenario, we don't have the acreage.
No.
So I'm sorry, I'm talking about my company right now. So what Kites has started to do is there's one phone call, but we manage all these three. So here, different kinds of people are taking care of healthy aging people. There is the attention page to is more to healthy aging when it comes to retirement communities. Then when it comes to rehabilitation, it is more about getting the doctors, nurses, therapists, dietitians, counselors, etc. involved to ensure that they recover well in the optimal period of time. And then when we come to hospice and palliative care, again, attention is different. When we have to focus on pain management, comfort care, etc. The people involved over there are different kind of set of people. So there has to be somebody, one body like a geriatrician who is holding all these pieces together, ensuring that everybody is walking towards giving the desired clinical outcome. And which particular discipline has to weigh more in which kind of setup is what we need to decide when we are deciding the care plans for each and every individual. So yes, definitely the multidisciplinary approach is the way to go. There's no other way that we can think about.
Thank you. Dr. Radha, your views on that?
We must, I agree with both of you. Aging, the care or whatever it is, it's a complex one. It is not just health. You're not just focusing on health. You need a multi-pronged strategy to address many of these issues. Emotional issues are there, abuse is there.
Yes.
You also have to think about the memory. So it cannot be just one doctor treating the thing. So once they realize and they come together, like you say, occupational therapists, physicians, psychiatrists, psychologists, that's a circle of the thing which allows you to have a continuum of care.
Sure.
People are aware what is going to happen and how do we get together. It also helps you in putting up a personalized care also.
Yes.
If you want a personalized care, because in dementia or something like that, you cannot just treat them like just any other person. So to get this, you need the help of all of them, occupational therapists, let it be a social worker. The other thing what I was also saying is if you go to the hospital or you go to other places, unless all of them have worked together and assessed them, the treatment will not be complete.
No.
So that is very, very important. And the last thing is once they get together in the they also can come out with innovative ideas of or progressing the healthcare.
Yeah.
So it's very, very necessary that it should be multi-pronged and not one
Thank you.
section looking after the whole thing.
Now, in the interest of time, we have got last 3 minutes left, and I'm very particular about timing. So I'm going to put Madan on spot, and I'm going to ask Madan, what is your overall summary of what you've heard so far across all the 5 panelists, Madan?
So thank you, Raj. I think there are 2 different streams of thought emerging. One from Australia, where technology seems to be used more often when it comes to aged care facilities and is emerging as a key factor when it comes to addressing workforce shortages. In India, the situation, as Dr. Reema pointed out, I think it's evolving. I think the use of technology, it's slowly taking pace. Another challenge that actually came from your discussion, Raj, as well, is workforce. Workforce seems to be seen in different perspectives, and I don't see a uniform opinion coming from all the panelists. Because some of the panelists here, they pointed towards specializations, improving or increasing the specializations when it comes to geriatrics. So I think the question, also ma'am pointed out in terms of having a multidisciplinary care, having an extended group of health professionals being involved in aged care. And also, as Usha ma'am pointed out, in terms of scope of practice and skill mix to actually include a range of professions and also expand the scope of practice of mid-level providers. So I think the challenge over here is that the situation in India is gradually evolving when it comes to workforce challenges. And also this would we would also need to reflect on the research work which is going around. And very importantly, as you rightly pointed out, Raj, in terms of rural and remote areas and in terms of the population over there. So I think that's my very short gist. Is there anything else you want to add?
I think you're just spot on, bang on, Madan. Well done for that. I think in summary, I would say this initiative is brilliant. It's a wonderful, wonderful opportunity to bring outstanding fellows across different countries to see how we can actually start making this peer learning a reality, learn from each other's challenges, learn from what sort of things are working in each other's countries, and then take a cohesive approach towards where we can genuinely make a global impact in the space of aged care. Well, on that note, we have come to an end. So can I request all of you to give a huge round of applause to our wonderful panelists. And now that we are back on track, we can continue with our next sessions on time. Thank you so much, all of you. Thank you.
She's just going to give her stakeholder perspective. Dr. Leela. Dr. Leela. So, thank you all for joining us for the panel session, and thank you so much for actually keeping with the time. So we now do have a special presentation, Dr. Leela, who is going to be talking from the stakeholder point of view. So can I actually, Dr. Leela, to give a very short 2 to 3 minute presentation, please?
Would you like to talk from here? From here only you can talk. Pardon me? You can talk from here only. I can do that. Whatever. It's not a big thing, you know what I'm going to say. Not even a big thing. Just 2 minutes. Oh, am I the only one here? I don't know. Thank you. All right. I'm Leela Krishnaswamy. I was invited here as a stakeholder in an assisted living facility. I'm a resident there. I was supposed to speak
after Praveen and Indu, who are founders of this facility. But unfortunately, they're not here. So let me begin by telling you a little bit about this facility, the genesis of this facility, which is very fascinating. Very short, of course. Indu and Praveen nursed Praveen's parents through the period of their ill health. I don't know the whole story. I really don't. So let me tell you very briefly how this came about. The idea of elder care. How did this come about? It is because they took care of Praveen's parents, and they found that to be quite a harrowing experience. It's not easy. So when they lost them, they thought to themselves, you know, everybody goes through this period. So if there is something that we can do to help them out, so be it. So they started a small facility with about 15 or 20, I think, elders, and they helped them. And then they were asked, I think this is the story, I don't really know, to help out with a much bigger facility called Chaitanya. Dr. Jairam, I think, was the one that approached Praveen and asked him if they can help them out, because this was a brand new facility and they had no clue how to go about taking care of the elderly in such a large facility. And that was spread over half an acre, I think. Anyway, that is where I went. And they set it up, and they were responsible for that for about 5 years, I think. And then they decided to set up their own facility, Anandam, which is where I am at the present time. So I had intended to tell you the software part of running this facility. That was my task. Since they are not here to tell you what really goes into setting up this facility, which is a gigantic task by any stretch of imagination. It's not easy, but they've done it. That's why I wanted them to be here, because it's such a fascinating story. But unfortunately, they are not here, but whatever. So let me do my bit, which extends only to about 2 minutes, I think. So I had to write it down for 2 reasons. I wanted to make it meaningful and short and precise. And since my memory has begun to dance to its own tune, I wanted to make sure I said everything that I wanted to convey to you. But I've made it as brief as I can. So please bear with me. So let me start off by saying good afternoon to all of you. Since I told you Praveen and Indu were supposed to talk, and they have made this whole thing, they've honed it to such perfection. They're such masters in this. That's the reason I wanted them to be here. But anyway, so if they did talk, what followed would have to be a natural corollary to their inspiring story. That is what I will provide. It is the software aspect of running this unit at a sustainable level. I moved into this facility over 5 years ago when I was 85. I will be entering my 92nd year in a month's time to date. Anandam is the name of the facility. It is housed in a 4-storied building set in serene surroundings, hidden away from all manner of traffic, where life goes by calmly. Praveen and Indu infused soul into this brick and mortar facility. And running this home is a shared responsibility. Indu charges up the atmosphere every now and then with her creative mind when she celebrates festivals and other events to relieve us from the staidness of our lives. The care they give us is to be seen, to be believed. Their day begins at the crack of dawn, stretching into the wee hours of the night. They are perpetually on call. Indu keeps a watchful eye on the dietary requirements of each resident, ensuring that we stay healthy. Aging brings on its own set of challenges, physical, mental, and emotional. To deal with it all with equanimity is a skill set that few of us are equipped with. Their vast experience places them in a niche spot vis-a-vis elder care. All this comes at the enormous cost of foregoing personal interests and needs. I characterize their journey as spiritual. They are wholly committed to the task of their choice, always thinking of where the next spark of happiness for the residents will come from. I have watched them operate closely, and I thank them for infusing hope and happiness into our lives in our twilight years. I will quickly end by addressing just one FAQ that comes my way. How do you keep yourself occupied in such a constricted space, knowing that you led an active and enriched life? I have an array of interests, including reading, writing, music, politics, and a general curiosity about the world around me, with help from my iPad and iPhone. It is therefore important to cultivate one interest that you can pursue on your own. Otherwise, life gets lonely. Thank you for bearing with me through this account. Good day, and God bless.
Thank you so much, ma'am, for sharing your experiences. Just to let you know, everyone, the paper presentations have already started in the boardroom. So please, if you want to be with the paper presentations, you could go to the boardroom, which goes on for the next hour, followed by lunch.
Check. Hello. Hello, check.
Hi. They want me to speak for the event.
Right.
Okay, what should I say? Okay. Start? Yeah. So it has been a very well organized technical event, and I really congratulate Ramaya Medical College to organize this so nicely, and they could bring in so many experts across the globe for this event. And overall, technically, it has been very empowering and enriching. However, the hospitality and the arrangements, like having sessions without any glitches, having ample opportunities to interact with colleagues, and developing those kind of collaboration. So it has been a wonderful experience, and thank you very much to the institution and the organizers. Thank you. I think it was okay.
Sir, would you like to do?
I don't know.
I'd like to. I'd like to thank Ramaya University for hosting this Asia Pacific Aged Care Hub and hosting us. It's been a very wonderful experience so far. Since I arrived here from Australia, being the part of Asia Pacific Aged Care Hub team, the hospitality is like really wonderful, and I feel really comfortable being here in this beautiful city. And then coming to this, the campus and the medical school is also really kind of very illuminating in terms of the things they are doing here is encouraging and really good. The other thing is in terms of the hub itself, the way they have actually organized the program is really top-notch without any technical glitches. Having to connect with a lot of people who are joining online is also great. So far so good. And I would say that I would like to thank Ramaiah University on behalf of all the people from Flinders University and part of Asia Pacific Healthcare Hub. Thank you for organizing this, and then I wish everybody have a really fruitful and a very good learning experience in the next 2 days. Thank you.
All right. Thank you very much for organizing this contemporary event. I guess a step much needed in the Indian context. Thank you very much for organizing this event, Asia Pacific Aged Care Hub. This is a much needed step looking onto the demographic profile changes in India and elsewhere in the world too. I'm very happy to see that there is a very good debate and the discussion on adoption of technology as an enabler. And myself coming from a technology field, I strongly believe that technology can be a very good and very strong enabler to provide care to the aged population in a very, very comprehensive manner, cutting down onto the cost and quality of care too. And I hope that this kind of an event takes place more frequently across the country, brings in stakeholders across different industries, and see that we have a better participation, more cohesive collaboration to provide, the benefit of such events across to the aging population in India and elsewhere too. And I thank the organizer for putting up this fantastic show. Thank you so much.
Thank you so much. Sir.
What is there?
No, sir. The camera. Yes.
I congratulate APAC for organizing this international policy forum at Ramaiah Institute, Bangalore. Very happy to find subjects covered are quite extensive and meeting the current needs of the growing elderly population, not only in India, not only in Asia, around the world. I think subjects covered are very useful. Every aspect is very useful. And very happy to find people from across the countries are speaking in these forums and also well attended. And I'm sure we have a lot of takeaway messages out of this conference when it closes 2 days later and a document is produced. All the very best, and thanks, congratulations once again to the organizers.
Thank you.
Stand.
Check. Can I speak? Not here. Hi, Harjay. Can you hear me? Yeah, okay. So just wanted to know whether James is joining us or not. I supposed to joining us online.
Yes, he's joining online. He told me he'll join online.
Right, okay. So I think we have got another 10 minutes, less than 10 minutes to start the panel discussion. So could you actually just follow up with him?
Yeah, I'll do that.
Thank you.
Check, check, check. Good afternoon, everyone. A small announcement before the starting of the session. All the delegates are kindly invited for the dinner banquet. So we request you to be at the Century Club, Bangalore. If you need any transportation from our side, you may please contact me. I'm Dr. Aditya. You can please be at the venue, Ramaya Medical College, at around 6 p.m. and we'll leave at around 6:15. Thank you.
All right, good afternoon, everybody. And so it's really a pleasure to see a plethora of aged care enthusiasts join here, for today and tomorrow for amazing deliberations. So we move on to the panel session number 2, themed Policy and Regulation in Aged Care, Challenges and Best Practices. So we have an amazing bunch of speakers, having enormous experience in policy and regulation. And so we have kind of listed down certain questions which probably the speakers will try to answer, and also from a different contextual perspective from Malaysia, India, and Australia. So some of the broad questions that will be addressed through this panel would include: what are the current challenges in aged care policy and regulation in Asia-Pacific region? The best practices in designing policies that promote vitality and quality of life of older adults in care settings, and how do international standards and benchmarks influence the development of aged care policies at the national and state level? And what role do community engagement, feedback mechanisms play in shaping aged care policies and regulations? And also we will be discussing about technology and innovation, how it's leveraged to enhance the effectiveness of regulatory processes and improve care outcomes of the elderly. And we go on with strategies adopted to address workforce challenges in aged care sector, and how can the policy makers anticipate and respond to future challenges and trends in aged care. And to take the lead, I invite, it's a pleasure to introduce the chair for the panel, Dr. Gangadharan, the founding director of Heritage Medical Center, and also he was a former president of International Federation of Aging to chair the session. I also invite Dr. Jyoti Katka, Associate Professor in Health Economics from Flinders University, Australia. So with that brief status, I would like to hand it over to Jyoti.
Thank you. And just two of us. No, I'll be inviting. Thank you, Teddy, for the introduction. On behalf of the chair and myself, I would like to thank everybody who are present here in person and also those who are present online. This is really fascinating that we have got so many delegates. They are actually actively participating in this aged care hub. This is much more than what we have anticipated. So this is the second panel discussion, which we are talking about very important topic that is on policy regulation in aged care. And that is very important because that we need to have policy and the regulation that actually facilitates aging in such a way that provides person-centered aging and also aging aging and aged care in a dignified way, and that improves the quality of life of people. So having that actually as a ethos for the policy and regulation is very important. So to discuss on that, we have got expert panelists from global perspective, from academic perspective, joining us here to discuss different aspects of policy and regulation and challenges and best practices. So we have two panelists who are in person here joining us here on the forum, and we have got other 4 who will be joining online. So those who are joining in person are Amrita, Kansal, and Dr. Umayam, who I would like to request the panelists to come over here at the dashboard. And we have 3 more, I think 4 actually. So we have the 3 actually joined online. So we have 1 more panelist. She's supposed to join online as well, but I think she might join us. Whenever she joins, then we actually entertain her as well. So before we start the panel discussion, I'll quickly give a short introduction to each of our panelists. So first is Dr. Amrita Kansal. She is the technical officer of WHO CERO. Dr. Kansal is a distinguished public health expert affiliated with the World Health Organization Southeast Asia region office, regional office, WHO CRO in Delhi, with a comprehensive background in public health policy and management. Dr. Kansal plays a pivotal role in advancing health initiatives across the region. Dr. Kansal is also committed to promoting healthy aging that reflects in WHO's dedication to achieving equitable healthcare for all age groups. She also provided a keynote speech this morning. The second panelist is Dr. James Sivner. He's joining us online all the way from Flinders University, Adelaide. Thank you for joining us, James. So James is an academic from Flinders University. He is a law academic with a significant focus on healthcare regulations. James' research interests include intellectual property and industrial property law, with a specific focus on software and biotechnology inventions, data privacy law, and health laws. In addition, James teaches law in digital age as a part of the Flinders University Bachelor of Law. So we have got Dr. Anupama Datta, who has joined us online. Thank you for joining us, Dr. Anupama. So Dr. Anupama is affiliated with Health Age India in Delhi, and is a dedicated advocate and leader in the field of aged care and elderly support. Her commitment to promoting age dignity, independence, and social inclusion for older adults has made a significant impact on the lives of countless individuals. Dr. Datta tireless effort underscore Help Age India's mission to empower and uplift the elderly community across India. The next panelist here in person is Dr. Uma. Dr. Uma is Assistant Deputy Director of NCD and NPHC and Department of Health and Family Welfare. The other panelist is our Professor Maupin Tan, who is also our APACH Fellow. Thank you for joining all the way from Malaysia. And she's actually in Malaysian hub of APACH. So Maupin Tan is a professor in geriatric medicine at the University of Malaysia, Kuala Lumpur. She obtained her undergraduate medical degree from University of Nottingham, United Kingdom. So before completing her higher specialist training in geriatric medicine in Northern Region rotation and doctoral research studies at the Institute of Aging, Newcastle University. So over the last 12 years, she has dedicated much of her time towards establishing aging research at the University of Malaya. While her primary research interest has been falls and syncope in older adults, Maupin is also the principal investigator of the ageless longitudinal study of aging. She is the medical director of Managed Age Care and Genting Dementia Daycare Center, and is a founding director of ACT for Health, a social startup delivering evidence-based health assessment and training to enhance the health of older Malaysians. So we have another panel member as well. She was here in person, but she had to dash out for another meeting. But she has actually promised to join us online. So whenever she joins us online, so we'll actually entertain her. But I'll just briefly give her our introduction. Her name is Dr. Maheshwari M. Bhaskar, and she's the program officer of National Program of Healthcare of Elderly in Karnataka. So with that, I think in the interest of time, we should actually start the...
Good afternoon to all of you. Thank you for all the good introduction. Thank you so much. And thank you to APACH for inviting me, particularly, Teddy, who called me and ensured that I'm here. I was reminded only one thing of this session. I'm not going to talk much about it, except to say, we had 97, one of the ministers, Government of India, Social Justice Ministry, called us for a meeting on experts on policy formulation. There was, after several rounds of discussion, that was the last meeting. She's invited us to Vigyan Bhavan. So we all went there, 7 of us were there from across the country. And when she came, she said, I brought all of you, paid you for airfare, I paid you for your food, I don't want you to spend more than 2 hours and then get out of this room. Exactly, she said, I'd never forget this because, I've come into the place after lunch, not before lunch, and I want to go out of this place to the airport. So that's the kind of time constraints that we have. Nice to have this and a very important discussion that you're going to have on this. And so I think since the questions have been already forwarded, let me address the first question to people who are on video to begin with on virtual mode. What are the current challenges in aged care policy and regulations in Asia Pacific region, particularly Malaysia, India, and Australia?
We'll start with Morgan.
Yeah. No.
Sorry. Hear me?
Go ahead.
Can you hear me okay?
Yes.
Yes, hi. Yeah, so we have huge challenges in Malaysia. One of the main issues is that we have a huge, aged care has become a huge industry, which is largely unregulated. We have now 1,400 aged care facilities. We don't know the exact number because we only 300 are counted and registered within our registry that is held currently by the Social Welfare Department. And we do have issues with care workers. There's always shortage of care workers, training of care workers, retention of care workers, and also career progression for care workers in Malaysia. And there's no funding for social care from the government, by and large. There's only 7 government-funded aged care facilities, and that has not really changed. There are also 2 nursing care facilities that's funded by the government. We do have a large number of non-governmental organization-funded care facilities as well, but they are only catering to independent older adults. So all those assisted living and nursing care will then be placed in nursing homes that are totally self-funded. So we have huge gaps in our long-term care funding, and we have been trying our best to have some regulations. In fact, there was a new act that was passed before the pandemic, but we've struggled to enforce this act. It's called the Private Aged Care Facilities Act, and it's only dealing with residential facilities. So most care is provided informally by family caregivers, mainly women, spouses or daughters, and daughters-in-laws, of course. And then we also have issues with the level of competency with the care, lack of training opportunities for the caregivers as well. And a lot of times people are placed in facility without proper assessment and not given the opportunity to rehabilitate to return to their normal function. Very few people of our older people who need care actually end up in residential facilities, only 1%. So most of the care is actually provided in the home, which we welcome. and very few of our older people live alone. They live in multi-generational households.
Thank you. Thank you. Do we move on to Dr.
Anupama Datta, because given that in Malaysia and then in India, a similar kind of thing about the aged care is largely there is not much of policy and the regulation available. So let's actually hear from Anupama Datta from the Indian perspective and move on to Australia to hear from James, where there is like policy and the regulation is well established.
You know, Anupama has been quite closely involved in the latest policy of 2011. And I happened to be one of the members of the committee. APACH gave a lot of support, and she happened to be one of those architects of that. Thank you.
So thank you very much for having me here today, and thank you for allowing me to present online.
James, can you? Yeah, sorry, carry on, James.
I'd just like to start by talking, by addressing the fact that I'm joining you today online from Ghanaland in the Greater Adelaide region. I pay my respect to Aboriginal and Torres Strait Islander peoples of the Aboriginal and Torres Strait Islander peoples of Australia, and I acknowledge them as the traditional custodians, the Kaurna people, as the traditional custodians of the Greater Adelaide region. Thank you very much for, first of all, introducing the healthcare problems, or the aged care problems, I should say, in Malaysia. So in Australia, the regulatory landscape is in a significant amount of flux. And you have to forgive me here because I've only quite come recently into aged care research as part of my interests in health policy. So what we see, though, is that there's a significant amount of flux in the aged care landscape and the aged care regulation landscape. And a lot of this ongoing regulatory reform is driven by the results of the Royal Commission into aged care quality and safety. And so this was driven after an incident here in South Australia where a man at a government-run aged care facility in Oakton in South Australia was admitted to a hospital with large bruising that no one in the aged care facility could explain the cause of, which led to a huge inquiry, a royal commission into the actual harms that have been suffered by people in aged care. So our aged care facility, our aged care regulatory model at present is delivered by the Aged Care Act and more recently the Charter of Aged Care Rights. In addition, the question of aged care workers, those workers, some but not all of them, are regulated under the Health Practitioner Regulation National Law, which is implemented in each state and territory. Much like India, much like Malaysia, Australia is a federal jurisdiction, so therefore we have some sharing of responsibilities between the states and territories. Generally speaking, the federal government is responsible for collecting taxes and distributing funding for aged care, and then those aged care services, much like Malaysia, are delivered via either privately owned organisations, not-for-profits, or a small number of state, territory, or local government-run providers. One of the issues that we've seen with this regulatory framework is that there's no legislatively mandated minimum staff levels, and instead the focus under the Act is on rationing care as opposed to offering healthcare as a right. The Royal Commission has uncovered widespread neglect and abuse of people in care, and I should also mention here that there's currently a concurrent currently there is also an inquiry into Australia's disability support services and welfare, and uncovering abuse in that sector as well. And there's a significant amount of concerning results. So the Royal Commission, in a survey which Moulds notes was cited by the Royal Commission, 1 in 20 aged care residents in Australia has reported being abused. From 2019 to 2020, there were 5,718 allegations of assault that needed to be reported under the mandatory reporting system. And of course, much like Malaysia, this is also occurring in the context of an aging population. In many developed countries, like many developed countries, Australians on average are living longer, which means that they're more likely to encounter comorbidities during their life. And simultaneously, there's also a decrease in the number of working aged Australians who can work in aged care or pay taxes. So there's a significant issue as well around burnout and staff retention. So right now, the government is currently seeking consultations as to how the current regulatory landscape might be changed in order to better support the rights of people in aged care. So thank you.
Thank you. Thank you. Do we move on to
of course.
Anupama?
Yeah, good afternoon, ladies and gentlemen. Good to see you, Dr. Gangadharan, after some time. And I'd like to say that, you see, if you look at countries like India, which are in the LMIC category, and which are traditional societies more or less, I think the biggest challenge here is perspective. How do we see the aging population? Do we still see them as a burden? Do we see them as a resource? And that's where the major challenge lies. If you see them as burden, somebody who's a care receiver, who needs to get pension, who needs to just get some basic support in social care, that's where the challenge lies. Because if you look at longevity, and if you look at longevity, then you also have to look at the kind of differences in the heterogeneity in the aging population. You have to look at, if longevity increases, the number of women who will live longer than men, what is their life condition, how will they respond to this, disabilities that will come with increasing longevity, care challenges that will happen. So I think the biggest, Dr. Kansal will speak about it, but I think WHO has been talking about adopting a life course approach, and which we have not done. When we save those children and those young mothers, then we ought to think about that these people will live well beyond 60 and what will happen to them. So that's one major challenge, I think, in perspective, that how do we treat them and where do we sort of take them. In India, for example, we still think like in Malaysia and, like that care is basically a function of the family. And it's completely changed, the family dynamics have changed, the family structure and size have changed. Out-migration from countries like India is really high, whether in terms of intra-country or, inter-country. So those factors impact care, social care. Then comes the healthcare chapter. Now, we have a system of healthcare which is geared to a certain kind of population dynamic. But we are not realizing that we are an aging society and very soon we will become an aged society. So how we are changing the architecture of the healthcare system is of big significance. Then comes the whole issue of the latest challenge of digital exclusion. Now, during Corona, we all found that it was much easier for every service to be provided online. But elderly people are completely handicapped in this respect. So how we are excluding them, it's a benign neglect, but we are excluding them from the new possibilities. So I think those are the major challenges which need to be taken care of. And the beginning has to be made by data collection and data analysis. Like those of you who are familiar with India will know that LASI has, actually laid bare the landscape for us. And it's not just the 60 plus population, it's also the 45 plus population. So we actually know what trajectories they will take. So it's very important for us to take that into consideration and, plan accordingly. If we want to keep informal as the major care segment, then we have to see how we want to do it. Like in Australia, Professor James was talking about how they found, abuse in the institutional care systems. But in India, we have also found that in family situations also the abuse rate is not very low, especially in urban areas. It is fairly high. It ranges from somewhere between 12 to 15%, which is not a small number given the Indian context. So one has to look at all these things, and law, I am not so sure how much law can, give us, law can just be a broad outline, but when it comes to social care, when it comes to family dynamics, when it comes to, social interconnectedness, I think it's very important for us to also change the perspective of people around us. Like we have this program where we sensitize the youth and say that one day you will also become old. So how do you treat elderly? And how would you like to be treated? So these are some of the broad challenges that I think countries like India are facing and need to actually quickly take cognizance of the fact. Because I think we will very soon become an aged society. And if we don't change the basic thinking and the basic paraphernalia, then we'll be will be very difficult for us to manage those challenges later.
Thank you. Thank you once again. Now, you want to say?
Yes, sure. I think it's really nice perspective from Malaysia, India, and an Australian perspective. I think that actually ties to a new the next question, where it's looking from the more global perspective. And this question goes to Dr. Amrita about are there any international standards and benchmarks available that influence the development of aged care policies at the national and state level in Asia-Pacific region?
So, talking about the policy, WHO's role has been basically to support the member states in developing the policies and programs based on the evidence from across the globe. So that has been our primary role, and we have been trying to do it as nicely, as adequately as possible. And we have examples like from RNNCH and from non-communicable diseases also, and many other programs, if we see, wherein the programs, policies, legislations were designed based on the learnings and the best practices across the globe. So the international standards or practices definitely influence the policy making at the national level. And I would like to also again emphasize that this process evaluation report, the UN Decade of Healthy Aging, which became kind of a platform which calls for collaborative efforts across the globe, and it makes provided a plan of action. It provided certain indicators, and these 10 indicators, which are very basic, like having a national level focal point, having a policy for against age-based discrimination, having a comprehensive care assessment program for older people, something like these. Those 10 indicators were very basic information, and when they were thrown to the countries in 2020, the percentage of countries which responded yes was quite low, and over a period of 3 years it improved. It improved quite a lot in all the 10 indicators. So whenever we set up any benchmark, or we set up any program, or we bring in any kind of global kind of commitments, it works. And we have seen it in our MNCH program, how the Millennium Development Goals, they were taken up by the countries as well as the government and the UN agencies, partners, and how the maternal mortality and infant mortality, they declined over a period of time. And I think so that there is no kind of doubt about it, that if we have indicators, if we have standards, if we have benchmarks, if we have any commitments at global level, it definitely influences the national level programs. However, we have to understand, if we see the Indian context for older people, or in fact not India, even the Southeast Asia regional context, we know that the older people proportion is increasing, is a recent phenomenon, and it is going to be, it's a very high velocity thing, and we are going to be aged society very soon, and we have very little time. So the countries are catching up. So 2011 only, India came up with the national program for healthcare for elderly, and gradually they came up with the policies, different policies. Nepal came in 2015 for the policy of elderly. So they are coming up with policies, they are coming up with legislation. As I pointed out in my presentation also, that countries are having, the 70 to 80% of the countries are having policies, programs, but the implementation, the resources for implementation is lacking. So implementation is not there. And when the things get implemented, so policy comes, policy paper, we all know, it doesn't give a vehicle, it is a broader kind of a guidance. However, the guidelines for doing things, how it will be done at each level, how this will be monitored, what kind of regulatory mechanism is needed, how it will work, how the quality will bring into this program. These all come gradually. So we are in this transition phase, and definitely this quality assurance mechanism through regulating aged care center or whatever care we are talking about is essential, non-negotiable, and the current mechanism where we even don't know how many care centers are there in India or in many other countries, and whether they are we don't have any parameters. So whether we cannot say whether they are good or bad or there is adequate facility or not, because we don't have any parameters. So these things will not be able to give us a good quality care. And quality is a right, first of all. It is a people's right, and it doesn't come accidentally. We have to make an effort to bring in quality, and regulatory mechanism is must. And we always have this as an academicians, as a expert, as a professional. We all have our voices and we all have our roles. That is why this UN platform, we always say this is an opportunity. We must seize this opportunity to raise our voices, to make everything in place for older people, which is going to be a big challenge in Southeast Asia for most of the countries. Thank you.
Thank you.
Yeah, I can
Thank you very much. Very nice to get.
Yeah, thank you. Really nice overlook from the global perspective. Just want to ask a question to Dr. Uma on how can the policymakers anticipate and respond to future challenges in aged care? Could you actually just give you insight on that aspect, please?
Okay. Respects to all teachers and greetings to the participants and all the chairperson, the APACH organizing committee. And I, being a clinician, a public health expert, and now as one of the policy makers in the program management, I just would like to say a few sharings of kind of information with regards to aged care. First and foremost, we all know that India was one of the, countries to ratify the UN Convention on the person's right for disabilities, which just came up in 2007. But following that was the Maintenance of the Parents and the Senior Citizens Act 2008 and the National Health Policy in 2011. So from then onwards, we have not had any policies as such. And since morning, we have been hearing that policies are there, regulations are there, legislations are there, but how much that's been implemented is just 22% or 25% because of lack of various other things. First and foremost is the manpower and the logistics and fundings especially. And again, I being in the National Program for Healthcare of the Elderly, which is a current program which is running under the NCD program, I was just having a chat with her that NCD by per se has several other programs, and under that, this program is something very small, and the focus and again the manpower and the review and the implementation level, it's just neglected, and because of again various reasons. And to say that to bridge the gap or to have an economized use of logistics, manpower, we have the National Program for Palliative Care. That's the NPPC together with the NPHCE, which usually moves in parallel, so that the manpower and the logistics and the other things, we can take the support of either of them, can be supplemented. In that way, the program is running across the state of Karnataka. This is with respect to Karnataka, and no doubt across India, both NPHC and NPPC program are together running under NCD. And literally to say and to be frank, this is a scenario which is going on. But no doubt, even there, we have the home-based care services given at the community levels, door to door, in the rural areas by the community health officers, where they are manpowers who are trained for giving such care. But far and wide, again, to say that the main gaps in the bridges is the lack of manpower, the lack of trained manpower. And now coming back to the anticipation of and the further challenges and looking into the future of what this care is. Now, all of us have been through the demographic transition. The heart of this demographic transition involves seeing that the disproportionate or the robust or ubiquitous and rapid development of this aged population over the past few decades, and just enormous. And within a period of few decades, we have seen nearly 40 to 50% raise in the graying population, and they estimate the projected value is just to reach around 188 million by around 2030. That's again something big. And the special features, and with this huge population, India no doubt will be the second largest, or probably might run into the first largest in the world to have the aged population. And some of the special features which are again challenges here when we anticipate is, first and foremost, the rising population of the graying elderly population, and secondly, longevity, increase in the quality of life and medical care and the rest of the things. With technology, we have the longevity of life from 62 to 63 years now falling to 67 and 68 years one. And then we have feminization of this elderly, where 51% come into the female gender. Then we have around 70 to 80% of all these elderly falling into the rural population, dwell in the rural or the semi-urban population, where affordability, accessibility, and delivery of the healthcare services is something very challenging, and out-of-pocket expenditure, which again is something which needs to be borne out by the elderly themselves or the social support of the family. And but for that, we have the old and the older 80+ population, which again are bigger challenges. And more than that, we have nearly 30 to 31% of them falling to below poverty line. So all these per se as a socio-economic one kind of a burden, the demographic burden. And the other side, we all belonging to the healthcare, at least I being the healthcare professionals, we would like to see that the National Sample Survey by itself says the statistics that over a period of previous surveys, the morbidity pattern and the burden of disease per se is very high in this group as compared to the regular population. That again by the anatomical and the physiological changes, which is a part of the aging. That apart, the non-communicable disease burden, which we say, be it as simple as hypertension or diabetes or cancers, which are again on the increase and more, and some of the illnesses which are, defects like the visual defects, the hearing defects, and even the oral health. We take it for granted that oral health, yes, it's something significant, but that again is something very, very important when it comes to the nutrition part of it, which again is something very, very challenging. And even though the elderly is in the high socioeconomic group also. So with this, we have, falls, fractures, disabilities, which are all a part of this age group are one of the biggest challenges, and lack of geriatric specialists is something very, very challenging. And despite all this, the frequent hospitalizations, the repeated hospitalizations, and we see that 88% of these, the geriatric, they are, home confined to home with the hospice care and, needing some kind of a palliative care. And when the age goes beyond 80, this percentage goes to around 27%, which is something very drastic and significant. So ultimately, with all this, they have the social insecurity, the financial insecurity, and, a whole lot of this burden. And one other important is unregulated old age homes, or these homes which are running, the lack of standardization and uniformity, the lack of SOPs where they are being operated under operation things. All this has to be regularized. And this apart, as per se with the medical education, I don't know, here there are experts to say that, lack of curriculum in the undergraduate levels, the geriatric curriculums also, and in the post-graduations also, we have very limited people who are coming out of with this geriatric thing. And those who have already been specialized also, the career aspects when it comes to the incentives or, the salary part of it, all this, it's a big challenge. And this is leading to migration of our own geriatric specialists to other countries, looks like probably. And another challenging in a country like India is, it's just not the health department or the health aspects. We need to look into the other, to give a comprehensive geriatric care, which includes a social support from the social welfare department, and then we have the Panchayat Raj department, the women and child department, we have the police people. So all this interdepartmental, intra-departmental coordination itself is something a very, very big challenge, and this is something coming up. But over a period of time, I think we should be going, and with the digital and the technology being introduced and they being handicapped, this is again something which needs to be addressed to. Of course, and obviously that all cannot be addressed at one time and overnight. We cannot see things happening. It's over a period of time, and that's the purpose and the vision and with the common goal that all of us have come together here with 8 countries or 6 countries around here across the Asia Pacific, and getting into the concept of, or seeping the concept of, healthy aging, even in the youth population and across the world. Probably we will be able to give a decent quality life to all our geriatric population. And since even we, over a period of time, will slip into the same population, so we need to have a strengthened and, a good delivery and other things from collaborations into various private sectors and the NGOs as well. So with the common and the most famous phrase of the Sanskrit phrase of Vasudhaivam Kutumbakam, it says that, the whole world and the planet is one family, and we just cannot have disintegrated. And with an Indian kind of a family where the deep roots cultures are rooted in the deep culture, that's again another challenge, because the way the elderly perceive their thing, it's difficult to change them and get them back to the mainstream. With there needs a lot of behavioral change, and those kind of things is what we have seen over and across. So with this, I thank the organizers and I thank everyone and the chairperson. Thank you.
Thank you, Dr. Uma. I just want to actually bring in Dr. Anupama Datta here. Given that, ma'am, you're actually experienced in the work you have done in policy for a long time. Just wanted to actually know your perspective on what are the future challenges in aged care and how policy can address those future challenges, do you reckon, in India?
Very difficult question to answer, I think, because we can only go by the estimates that are available to us, and we can only go by the possibilities that we can think of. We really don't know what, after 20 years, what the world will look like, how much generative AI will take over, how much robotics will take over. We really do not know. But some things are for sure. We know that they're here to stay. One is, of course, increasing, longevity. That is for sure. We'll have more and more aged people, and we'll have more and more of 80+ population. So I think that's one trend that we should certainly look at. And the doctors on the panel just told you that, they require hospitalization, they require special care, they require assistive devices. So we have to, like I said, in the previous answer also, that, we should try and understand what is the implication of this longevity that we have found ourselves, and how do we deal with it. We are not certainly going to deal with it the way we dealt with it all these years, because when Bismarck started this whole social security concept of retirement and pensions, people were only living 2 to 3 years more when they were 60. But today they are living 20 years, and women live 25 years. So even if they contribute to a contributory pension fund, how do you make sure that the entire lifespan is, safe and secure financially, at least? I'm not talking of health here. And of course, preventive healthcare, which is, I think, one of the very, very, neglected aspect of health, preventive healthcare. Dr. Kansal mentioned about healthy aging. Now, how many of the institutional systems are encouraging people to become healthy? How many of the smart cities are encouraging people to exercise? Now, that's a very, very important thing. How many of these smart cities are building, emotional connects and, other kind of social connects, so that people are not isolated and are not prone to suicidal tendencies? So these are certain things which I think we should look at, and to the current challenges of, like I said, financial security, digital exclusion, social exclusion, and the other things. We also now have to deal with, climate change. For example, how are heat waves going to impact the lives of the elderly? What difference will it bring? Something like COVID, it's not. We were always thinking about NCDs, but now this particular disease has actually, told us that NCDs become worsened, when you have COVID. So how do we deal with these intersections? Dementia and mental health, very important concerns for the elderly, I think. These are some concerns which I think are very obvious. We ought to deal with it. Older workers, how do we reskill them? How do we give them opportunities for continuing to be, not just usefully occupied, but also earn enough money for them to live their last their lifetime. It's very important because if you look at the elderly population, I think most of the challenges are that in the organized sector particularly, that they lose the roles that they have been used to playing. Women, the doctors will tell you, are facing this very big challenge of emptiness, that they play the role of nurturers all the while, and suddenly their home is without anybody to nurture. So is it that we will find them some new roles in society? Is it that we'll, how will we deal with those issues? It's very important. And of course, most important is technology. How will technology, help us deal with these challenges? And how ethical and how empowered we are when we are older adults to deal with this whole, this technology thing. I see a lot of startups in the segment, which are dealing with, which are actually bringing up these new solutions. The new apps are there. You can use the health apps, you can use the social media apps. But is my data secure? How much of it should I share with others? Do I know that? And is the regulatory body dealing with it? If you're looking at institutional care or care at home by outsiders, then training of caregivers and regulation, like James was saying, that they found cases of abuse. Now, do we have a mechanism in countries like India where we deal with abuse in a very, very systematic fashion? At the moment, we do not have even a law where a policeman can register a case of abuse or crime. So these are certain things which, like I said, that architecture has to change. And climate change, for me, I think is a big thing. Climate change will impact a lot of things, and the indirect impact will be found on, for example, agriculture. To look at how climate change is impacting agriculture, and in India particularly, we find elderly people more into agriculture. The younger generations are all moving out. Food security connected to climate change and agriculture. People living in low-lying areas, which are prone to multiple droughts and floods and whatnots. When people move out of those areas, where will we go? How will it impact their social connects? Like we all know that after displacement, it's very difficult for elderly people to be reconnected to their social network. These are some very big challenges, but I think the best way to tackle this challenge would be to think global and act local. I think it's the community's role and the role of the these local self-governments to actually be very active in this sphere and start planning at that micro level, because I think that's where the real solutions and organic solutions will come. So that's my bit. I'll be happy to take any questions if you have any.
Thank you. Thank you, Dr. Anupam Dutta. I think we have less than almost just 5 minutes left. So before I think we conclude the session, I think we just have to actually address one of the issues that's actually talked upon by all the panelists about the workforce in aged care. So just wanted to basically kind of just put a spotlight on Professor Maupin on just to talk about this workforce issue. What are the challenges of these workforce issues? How policy and regulation can be actually developed and implemented so we can actually address these challenges of workforce in aged care in general.
So Malaysia's issues kind of lie between UK and Australia and India and Nepal and Philippines. So we do need to consider ethical recruitment as a short-term measure, because at the moment we recruit unethically. So we do need ethical recruitment to actually plug the gaps in the short term. But in the long term, we need to think about training, career progression, training our workforce and ensuring that they continue to upskill and there's a career progression. They either become more and more senior caregivers, moving into managers of the centers and aged care operators, or they could become case managers, or they become trainers. So, and it's very important to think about for retention purposes. But there's another side of the workforce issue. So the workforce issue no longer exists if you don't need that many people to care for. So what we do really need to concentrate on is to reduce the total number of older people who require care, and that can actually be achieved in a relatively short space of time. So number one, you need to regulate the practice of doctors, and particularly in private healthcare. So when they cost the price of an operation, the care of rehabilitation needs to be costed in, and the person should also be given the correct information on how to make sure that after procedure or after an acute illness, they are able to actually restore function to normal levels. Because what we're doing is we're just helping people live. We're not helping people live longer without disability. We're just making them live longer. So that is probably the best solution to addressing the workforce issue.
Thank you, Mopin. In the interest of time, we have got just about 2 minutes. I just want to actually ask our chair, Dr. Gangadharan, to just give a summary of this panel discussion, and also after that, just close the session as well. Thank you.
Thank you very much. Very interesting session. I think we are talking about policy and its implications. Thanks for all the panelists who have communicated their desires and concerns. I just looked at how do I conclude. So I just picked up 3 points out of all that you said. One is, though we have not touched much about income, Anupama mentioned that across in the last session, which is income. I think, in my opinion, when a whole person has no income, I think there's no respect for the person. I think one of the biggest problems is dignity in life, and there is no income. The second is health. I think a lot is spoken about health all of the session. We are limiting ourselves to senior citizen health. I think when the income is there, health is not a problem. When health is not there, then comes the problem of abuse, which James very clearly mentioned. And we are talking about, care. Care is at the third aspect. So we are looking at policy formulation. I think these 3 factors are the primary, determinants on which you build on all those issues that come up. And first point that I thought when you're talking about the formulation, purely out of what you discussed, I'm not bringing my own points. One is evidence-based. I think, WHO also made a representation. I preferred that point. Evidence-based policy making is something that perhaps, I don't know whether India has reached there, but India has, in the recent 10 years of time, carried out a lot of research. One has been done by the United Nations Population Fund, UNFPA India. And second is a LASI report very recently. And then NSS studies have been always coming for over the decades. And then there's also been a technical committee appointed by the government of India's health department. That's a 4th report. I think those evidence, how much are we relying on formulating the policy? When we did the policy of the India in 2010, we never had so much of documents. The only thing that we could rely was on NSS. That was extremely very old. I think today we have more document to, if somebody is going to formulate a policy, I think evidence is an important thing that every one of you mentioned. The second is, I think from morning, everybody has been talking about resources. Having a policy is only a marketing statement. Just to say, I have wish list. It's a wish list, but no implementation. Funding has been one of the reasons India has suffered as implementing the policy. The third thing is talking about resources, funding resources. And the third point is on technology. I think it's taking a big shape. I think we heard this morning about technology taking a big shape, robots taking a big shape in Australia. I think that's a third thing that we are taking that point today. And fourth is climate change, an important aspect Anupama touched was on climate change, which probably we are forgetting, that it's having a lot of implication in India. And I think the last point that I wanted to check out of this is, I think so, that's only 3 for human resources. Ultimately, nothing happens without human resources. Technology may come, technology may go, but we still need the touch of a human being. These are the 5 points I think are raising out of this last 1 hour session. Thank you once again. Thank you, my dear friend, for co-chairing the session. Thank you all once again for coming. Thank you all for coming once again. We enjoyed the session. Yeah. Thanks to the organizers for having this. Thanks, Deti.
Let's put our hands together for the panelists. Thank you. Thank you. Thank you very much.
Just have a group picture.
Yes, thank you.
You can have the online panelists as well. Yeah.
Okay.
So the online panelists also can say cheese on your monitor so that the picture would be bright and shiny.
Thank you so much.
Thank you.
Thank you.
So before we move on to the next session, which is the round table, The venue for it will be in the adjacent room, the board room that we are having, so that you can stretch your limbs. From morning we have been sitting, and I've been told that the temperature of the room is a little bit cold. So we will try to increase that. You can have a bio break for 10 minutes now. We are going to start the next roundtable session at 3:45 in the boardroom. But before that, I would like to invite all of you to the evening dinner, which will be hosted by the Ramaya Institution, Flinders University, and the APAC group at Century Club. We are going to send you the location. It's in the heart of the city in Cubbon Park, right next to Vidhana Sauda. Century Club is the venue, and 7:30 onwards, because we want to give you some time to take rest in between. And the traffic being the Bangalore traffic, you need a good half an hour to 40 minutes from this place to reach Century Club. So please do join us. We have arranged for a few vehicles, because we are not very sure as to how many of you would be actually coming in. So please meet Aditya, our team at the reception, to say that if you need a vehicular support, so you can just talk to him and we will try to organize. Else you can use any of the Uber or the public transport to reach Century Club at 7:30. Now the tea and refreshments are served at the same area where you had your lunch, in the yoga lab. And sharp 3:45, because we have to, fortunately we are keeping up with time thanks to everyone over here. We'll meet and have the roundtable discussions at the boardroom adjacent over here. Thank you. for the team to come in here. So we'll sharply start in a minute. Good afternoon and good evening to all the delegates and the online panel members. We are going to start in a couple of minutes, and I thank you for your patience. So good afternoon, good evening, and probably in some places, good night as well. So we're going to start the session on the role of technology in aged care, both the opportunities and challenges. From morning, we have been having amazing speakers talking about aged care, aging, and care of aged. So when we look at it, technology as an enabler, technology as a barrier, technology as a leveler. So these are the three things where when we see probably the example that we give in healthcare is the Bond movies. When we see some of them from 70s movies, what was science fiction has become a reality. And what is reality in some places can't be put in place because it is still a fiction. So when we look at technology, technology has not failed, but when we look at use of technology, probably there are some constructs with ease of adoption, intent to adopt, and also the construct of adopting and adapting a technology in a given location. Many a times we have seen the best of the best available technologies when tried to contextualize in a different environment, its role and its effectiveness might not be the same. And also we have seen that what works in, let's say, a sector A, what works for financial sector in terms of blockchain, in terms of encryptions, when we look at health data, it might not be similar, though we need the same standards. And also we have looked at cross adoption of technologies from one domain. Many a times something which was made for manufacturing, something which an algorithm which was made for supply chain is being efficiently and effectively used in healthcare. So in this context, probably today's panel, we will try to explore what is the role of technology, and being in 21st century, as somebody was mentioning in the morning about the large language models, generative AI, Industry 5.0, and also the emerging machine learning algorithms and robotics, we are in a different paradigm altogether. Very in near future, probably in 3 years or 5 years, what we are thinking are challenges which are insurmountable with the leap that we are having in quantum computing, with material science research that is happening, with shrinking of technology is what we say, wearable devices, low energy Bluetooth. We will be seeing a sea of change, and the benefits of cross adoption of technology from multiple domains will happen to human life. I'm not even talking about health, but human life. Most of the technologies are human centric, are here to enable and empower. So in this context, probably we have a very brilliant constellation of certain speakers on this round table. Pun intended, it's a square table that we are sitting at, but the round table. And the flow would be like, we have some experts who have what we called as use cases, so to speak, where they have adopted and when they have used, and some of them have sort of like surpassed the challenges of technology. So we will be having a round of sort of like 2 to 3 minutes or 3 to 5 minutes from their perspective as to what they perceive the usefulness of technology utilization for aged care and in aged care. And then we will have a few questions which can be put onto the chat. And also we have a very good number of people in this hall. And I'm proud to say that this Asia Pacific Aged Care Hub International Policy Forum is running across 6 countries. Offline, we have 75 registered delegates with another 40 to 50 delegates who have been invited as speakers, roundtable members. Additionally, we have across the different countries, 175 registered and around 300 to 350 online participants for this wonderful event that is being hosted at Ramaiah Medical College in association with Flinders University, Asia Pacific Aged Care Hub, ARIA, and also supported by the DFAT and Australian Awards Fellowship Program. Now I would request my co-chair, Angie, to introduce the key people in the round table, and also we will have the session thereon. On to you, Angie.
Thank you, Professor Nandu, and thank you to our esteemed speakers for joining us today and sharing their insights from across the globe and multiple time zones on the role of technology and innovation in elder care as we delve into the different opportunities, challenges, barriers, best practices, and many success stories that we very much look forward to hearing. I'll just give a brief introduction to each of our amazing speakers who are going to be speaking today. So on my left-hand side is Associate Professor Andrew Cibola, who is the research lead of the Australian Industrial Transformation Institute at the College of Business, Government and Law. Andrus's research currently focuses on various facets around the future of work, especially exploring the ethical ramification of artificial intelligence in workforce and trends in automation and innovation. I've got on my right side, so I got my right side and my left side right for a change. I have Professor Raj Shikwat, the Dean of Research, Education, Psychology and Social Work, also at Flinders University, a global citizen at heart. Professor Raj is an internationally recognized award-winning academic mentor, keynote, TEDx speaker and scientist with experience spanning 4 continents and 6 countries. I also have Mr. Muto Singaram in the room, also on my right, to Professor Nandu's right side, actually, who is the CEO Incubation at Healthcare Technology Innovation Center at the Indian Institute of Technology, Madras. He's also the founder of Vibazone, with over 30 years of experience in engineering, management, and entrepreneurship. He's a mentor and entrepreneur in residence in several universities and the author of 2 books on entrepreneurship. And then our amazing speakers who are joining us online. We have Mr. Lee Martin, the Chief Executive Officer and Director of Care at Lutheran Homes in the Barossa, who oversees all the operations of the aged care facility, financial, clinical, and general services, with a very long history and background in nursing and military service as a lieutenant colonel, starting his career in aged care in 1994. We also have Associate Professor Donald Manlapaz, who's currently the chair of UST CRS Department of Physical Therapy. He's also our 2020 PRC Outstanding Professional in Physical Therapy and the project leader for the Philippine government-funded Grace Hub for Health Innovation. And last but not least, we have Ms. Sarah McRae, the Chief Executive Officer at Calvary Ampler Health Joint Ventures, who oversees not just everything around the amazing virtual home hospital, but also the full accreditation NSQHS standards, with experience working in both the public and private sectors across Southern Local Adelaide Local Health Network, Chief Operating Officer at Women and Children Health Network, prior to moving to the private sector in Australia. Thank you very much to our amazing speakers, and I will hand over now to Professor Nandu to facilitate the next part of the discussion.
Thanks, Angie, for that introduction. Probably I would request Lee Martin to share their experience, because some of us who had been to their wonderful center in Barossa Valley and Tundra Homes, what is the role of technology in aged care as you would envision? So could you please unmute? We are just, yeah.
Here we go.
Yes, we can.
Thank you. It's certainly a pleasure to be part of this roundtable discussion today. At Lutheran Homes Barossa, we are very much into technology. At the moment, we've actually deployed 10 different types of robots to support the staff in what we do here best at Lutheran Homes Barossa. Our robots are very much involved in doing back of house or comfort or socializing with humans. The robots are there to support our staff, not replace the staff. And what we're finding is that the more we delve into robotics, the more there is to learn. And so what I am hoping as a result of this discussion around the roundtable is that throughout the Pacific Asian Ring, we start talking more about what are the most suitable types of robots that can be deployed into an aged care environment, or into a disability and home care environment as well.
Thank you very much. Following on from that amazing example around innovation, if I can ask Sarah to also showcase and share with us the amazing case study around virtual hospitals and technology in Calvary-Amplar and its significant impact on delivering care in South Australia.
Thanks, Angie, and hi to all. So we're very privileged to be able to deliver virtual hospital care across South Australia, but we've also done it around Australia as well. And it really is a true substitution for a hospital bed. And we've been able to do that with the use of technology. We have done a pilot in relation to wearable devices, which we've applied both to those that are in aged care facilities and those outside of aged care facilities within their homes. We did find issues in relation to the wearable devices, and hopefully we'll have further discussion about that through this panel tonight, just in relation to the requirement of just that continuous monitoring and that data collection. And if a person needs to be monitored 24/7, then you've got to ask the question, actually, do they need to actually be then in a bricks and mortar of a hospital rather than being treated virtually? Do they need to be in an ICU or HDU? What we do use through the virtual hospital is we use an iPad with a SIM in it that we give to each of our patients. And then we Bluetooth monitor the patient with an oximeter, blood pressure and a thermometer. We have a virtual care centre where the patient then is monitored and they can call in through the iPad to us. And then it's a very much medical-led model. So the doctors will do a typical ward round with them at least once a day. And in reach into the aged care facility. And, in Australia, there are many GPs that are attached to aged care facilities. And so it is our role to make sure that there's good, robust communication when they're admitted into the virtual hospital. So we do daily calls to the GP and to the nurses to ensure that they understand what we're doing from a virtual hospital perspective. The program that we're running here in South Australia is only for acutely unwell patients. So I'm sorry if the language is a little bit different, but basically it's tier 1 level care. So it is absolutely a hospital substitution. And the way that we're funded through the government is only if we are delivering that acute care. It's not for subacute, and it's not for any of sort of the rehab components. It's really a replacement of a bed. So we've been very fortunate to do that. We've been running this program now for greater than 3 years. We've had a lot of trial and errors. We built our own electronic medical record. This virtual hospital was built before COVID, and so there wasn't anything that we could sort of pull off a shelf that gave us that end-to-end full hospital treatment pathway. So we've built our own through different systems. We still believe that we've got a long way to go in that sense, and there's a lot of investment that we can do in relation to building the EMR, and we have sort of add-on systems to support that, such as MedChart, etc. We have a platform that assists us also to ensure that we are monitoring those vital signs, and whenever there's an alert, etc., that then triggers into the virtual care centre. So we've treated over 14,000 patients here in South Australia, and around Australia we've treated greater than 200,000 patients. So we've taken a lot of learnings over the last 3 years.
Thank you very much, Sarah. Such insightful applications across both your institutions, from robotics to fully virtual hospitals, EMRs, wearables, and remote monitoring. Professor Donald, can you also give us some of your insights around the role of technology within this space?
Hi, thank you for the invitation. So basically, I'm a physical therapist, a physiotherapist. So our medicine is really exercise. So I'm one of the proponents of what we call exer gaming. So it's an exercise and gaming combined. So we use AR and VR, of course, to promote physical activity among older adults, particularly those with knee osteoarthritis. But currently, I received a grant from the government, and that is the GRACE Hub. The GRACE Hub stands for Generating Research Applications, Care and Enterprise for Health. We established this specific hub so that we can synergize and have this kind of technology a home so that we can also collaborate with other disciplines in the university. Basically, what we are doing right now is to collect all the health innovation funding coming from the government, and these products will be utilized in other products such as robotics and other technologies and tools for rehabilitation and for exercises will be utilized clinically and also to the community. We're also looking at different activities, not just inside the university, but also a national level activities so that we can promote this kind of health technology hub. The problem in the Philippines is that we have a lot of fundings from the health sectors, but there's no synergy of those tools and ideas. So hopefully our, should I say, 6-month-old Grace Hub will have a lot of experience and opportunities so that we can maximize our resources. Thank you.
Thank you very much, Professor Donald. It's fascinating to see how VR has moved now much beyond Pokemon to now utilizing that state-of-the-art technology in so many applications. And actually having a lot of funds is a very good problem to have. And I look forward to see how that is going to be utilized to impact the community even more.
Continuing with the experts in person, I have to my right Muthu, and his experience is supporting startups. And in the recent past, when we actually look at the scenario of startups, the food tech, edu tech, and health tech are the leading what you call as the startup buckets in which we can see. So if you can just throw with your experience at IIT Chennai startup ecosystem, what are the challenges and opportunities for startups specifically to aged care, if I can ask you?
Thank you for having me here, and great question. Let me think about this one. Often running a healthcare incubator is not as easy as running other incubators because it requires a lot of regulatory framework, which most startups have no clue, and say the least, they don't care. So they start coming up with stuff which doesn't work. So we ran last year a program for aging, where Government of India actually paid them a fellowship program for 18 months, where they were paid 50,000 rupees, which is not a bad stipend to come up with some ideas. And then we gave them in between 5 lakhs of rupees to build a prototype. So a couple of things they came up with. One was that they discovered a lot of people have struggled to sleep. So they were trying to look for solutions, how to make people sleep better. That was one. The other one, which was relatively useful, was very simple, was how to get up from a wheelchair to use your toilet, for example. So I actually helped them to come up with an inflatable cushion where they can just inflate the cushion, which will lift them up, and they can use the toilet and then deflate the cushion, and then they can sit back on it, so they don't need to take somebody to the toilet with them. Now, what I think a lot of us miss, we only talk about old age, assistive, and so on. I think assistive technology has now taken a big role in India and many parts of the world, and a lot of us need assistive tools, not only elderly. So what we've done is some of the assistive things which come out of for assistive, for example, people who, for example, this is an assistive tool, even though we might not really realize that. So a lot of the time, old people have hearing problems, eye problems, which already exist. So we can adapt those in. 2 other areas which I think is important, and we've been talking about this. One is a social angle, and the other one is also how you'd help them socially to help them. Most people, when they get older, they don't have company. So maybe technology can play a role, like using virtual reality. I was trying to build a device. If the mother touches you physically, you can transmit to the other side. But it didn't really work, but I tried it, and nobody wanted to work on it because they said it's too science fiction. So what I said was, and in India, weddings are big, right? So I said, if we can build this, the blessing can be done physically from anywhere in the world by doing this. So I got about 10 people together to build this. But after a couple of months, they all left because they said it was just not feasible, because when you pressed it, it translated the pressure sensors were giving all the wrong readings. The heat was not working, so they quit. So that's an area I think it's possibly a good way. And I think one of the speakers said, robots are not there to replace, but they can always be useful, especially for companionship. So if you want to watch television, you could program that robot to agree to everything you say, right? Keep you happy. So that is something we can do. And the other area which I think we really need to work on, and it's gaining a lot of ground in India, is mental health. And especially giving them to play Sudoku, playing puzzles, keeps their mind active. So I think those are some of the things startups could look at. And I think, unfortunately, this area, the governments have to also play a role, policymakers, to make it easier to get regulatory approvals, maybe give them funding, and also the people who are going to buy this are usually through things like NGOs and so on. So I think that's something we have to look at. I'll stop there and give the mic before he pulls it off me.
No, thanks, Muthu, for that. In fact, like when you're talking about the human touch, telemedicine or telehealth has been accused of robbing that touch. Especially they say that when it comes to clinical care, the doctor's healing touch has to be there. And today when we talk about training our surgeons in a haptics feedback lab, we are having the reverse touch where a surgeon is able to feel and get the tumor in a virtual reality, augmented reality mode. So it won't be science fiction. As I was saying, the Bond movies, what we saw, today we are using the mobile phone and doing much more than what Bond used to do for good. So in that context, we will ask Andreas to provide his insights and what you would want to share on the role of technology in aged care. On to you, Andreas.
Okay, thank you very much. I was going to say it's never good to be the last speaker, but I'm not the last speaker. So, but I still say it's never good to be the penultimate speaker, because I'm just going to repeat what lots of others have, virtually everyone who spoke before me has already said. But I wanted to focus on aging in place rather than in residential care. And it's something that was briefly mentioned this morning by Dr. Umar, and who put a fabulous slide on the screen, demonstrating what technology may be required and possibly is available to make aging in the home possible. And as it so happens, the Australian government announced its budget a couple of days ago, and one of the key announcement was that an extra $500 million are going to be put into home care packages, which is the Australian version of supporting people to stay at home rather than moving it into residential care. And just to add a few statistics to that, there are currently about 500,000 people living in residential care in Australia. And then on top of that, we have 250,000 people getting these home care packages. And there are many more people who receive care without those home care packages. So if you need to add another 500,000 people who get aged care in some other form. Now, what I was going to talk about, and I'm running out of time very quickly, was two research projects that are kind of linked. One was about housing, and we asked and researched with older people how they would like to live in retirement. Now, these were people who were aged 55 and older, and also typically of low income. And one message that came out of that the kind of housing that they want is housing that allows them to be mobile. And then we did another project where we talked to, again, older adults, 55 to over 90, about technology, smart technology. And we asked them to discuss with us smart housing, wearables, autonomous vehicles, and robotics in the household, and how they would like to live with any of these as they grow older. And once again, the key factor that emerged from this was mobility. There was no outright fear or rejection of any of those technologies, apart from what we heard just a few minutes ago from Sarah, privacy, data, and what's going to happen with the kind of surveillance aspect of the technology that's being used in the house. General acceptance that having a variable that detects whether you had a fall, or even a kind of technology in the house that tells you you left the kettle on or didn't turn the oven off, and maybe something you should do about it. And ideally, let's have something that does it for you. That was perfectly okay. But the key thing was, these technologies should be enabling continued mobility in older age. A couple of concerns were raised, and I need to read them from my own notes here. One was a very strong concern that as we use more technologies, we're actually undermining our own cognitive and physical capabilities. And in a sense, it's a bit like people using Google Maps and can't read maps anymore, because that phone will tell us when to turn right and left and go straight. So that was one of the concerns, and it reflect on my own experience. It may be not entirely unrealistic and unwarranted. The main concern was that the smart technologies should be aiding the early detection of health issues. So it's the detection itself rather than cure and acting providing supports afterwards. And the third and fourth main points, and they're probably identical, a very distinct fear that we are going to use technology to remove human involvement. And nobody wanted that. So the clear statement was here, people wanted technology to be used to augment human carers and not replace them. So the human touch that we just heard Dr. Nanda referring to was clearly high on an agenda. And that was sort of the key findings from our research. And one other conclusion from that is clearly we need to talk to these people before we implement those technologies.
Thank you very much, Andreas. As we go along with many of those strong emerging themes on robotics and assistive devices supporting aging in place, I see a very important emerging theme around the importance of co-design with the consumers on what they actually want, which Andreas has shared with us very succinctly in his strong research, but also the importance of human factors. And that will bring us very nicely into what Professor Raj is also going to share with us in his next lecture.
Thank you, Angie. We all are sitting here and talking about the role of technology in aged care. And I would really invite all of you to think about the very last word, care. Care is very, very important. And I think when I was thinking about this topic, I thought, what better way than to reflect on my whole life and try and summarize my message with 3 simple but very, very powerful quotations which has really inspired my life. So I'll start with the very first one, Mahatma Gandhi. And Mahatma Gandhi very beautifully said, the best way to find yourself is to lose yourself in serving others. Very powerful words. It emphasizes so much on servant leadership. We are here for a purpose, and the purpose is to serve others. There's this Japanese concept called ikigai. Gai means reason, iki means to live. What is the purpose or the reason to live? And I think it's extremely important to anybody who is working in the sector of aged care to remember their true purpose and to have that servant leadership mindset whenever they're trying to do anything for the end users. That was number one. Second one is Maya Angelou, who said this beautiful thing that people will forget what you say. People will even forget what you do, but people will never forget what you make them feel. That's extremely, extremely important. Anybody who is working in aged care, we should remember that lens. It's how we are making people feel. And that is extremely, extremely important. The sense of having the genuine empathy, the sense of having this genuine connectedness with clients, with people in the sector is extremely, extremely important. That's going to transform things. And then the third one is a very beautiful African proverb, which says, if you want to go fast, travel alone. But if you want to go far, travel together. Now that's really profound. If we all want to achieve something much, much greater than our own individual strengths, it's extremely important for all of us to travel together, to work together. And which brings in this point of people from different specialities and different disciplines and different expertise and different skill sets to come together very, very cohesively and work together towards the bigger purpose and bigger cause. So I know we are talking about technology here, but I haven't spoken a word about technology here, isn't it? Just before starting this session, I was talking to Naveen and Anusha right here, and I was telling them how important 21st century skills are. They are called 21st century C skills, which is communication, collaboration, critical thinking, and creativity. These are the most important 21st century skills. Irrespective of what we do, as long as we are good with these transferable skills, we can make a huge amount of positive difference. So yes, technology is rapidly moving. Yes, technology has a lot of scope and space to be utilized to optimize a lot of things we do. But it's also very, very important for all of us to remember the higher purpose, remember empathy, remember care, and remember working collegially and cohesively together towards making a much, much, much bigger difference. Thank you.
Thanks, Raj, for actually bringing the whole theme of what we are discussing here. Before we go for the next round of specific questions, in the room, I see some of them who are working with the industry and some of them who are making products, technology products in healthcare. Health, that is a mobile health, is a very sort of, because like today we want the entire world in the palm and the whole life is in the mobile. So in that context, I have Mr. Kaushal from Kevin Tech, with whom we have worked on several projects, and they are working in the NGO sector, specifically in healthcare sector. So if I may ask Kaushal as to what are the opportunities or challenges that you see, especially in a country like India, where we have a 5G penetration in the remotest part, yet there are basic amenities that are lacking. So there is a very, what we call as a contrast setting where we can enable, especially with the government aggressively supporting the digital adoption for delivering healthcare in the primary care sector. So in this context, where do you see mHealth with mobile applications and use of smart and not so smart phones for delivering aged care?
Thank you. Thank you so much, Dr. Nandakumar, for inviting us and having us be a part of this wonderful session. First off, I'd just like to acknowledge the panel and the people who are part of this online as well. I think the kind of experience that everyone comes in with is wonderful to see, and it is great to see that all aged people are in good hands. That's what I'm able to see from this. We at Kevin Tech have been working in the field of public health over the past 20 years now, and we have faced a set of very unique challenges, I think, that we've been able to overcome with the help of technology. Talking specifically with aged care, I think a few of the challenges that we've seen over the past few years is primarily the lack of digital literacy amongst the population. I don't even need to go to the aged population, but in fact, generally lower income societies and the rural population itself are highly illiterate in terms of utilizing digital technologies or any kind of digital solutions for their benefit. That is one of the biggest problems that we've seen. The second problem that I see is
the lack of last mile impact being provided by either caregivers or by any kind of government schemes, that although there are many in the country of India, effectively these schemes being utilized and these schemes being implemented and having the focus group or the target group actually benefiting from these schemes are something that is still lacking. A few opportunities that we are seeing as part of our solutions, as part of the customized tech that we're developing, is primarily the concept of enabling or rather embracing technology to connect caregivers, to connect various stakeholders in terms of care for the elderly. I think this morning session, when Dr. Uma spoke, what she mentioned was that make sure that the elderly themselves remain responsible and they are active stakeholders in their own care. I have an aged grandmother who has Parkinson's, whom we take care of on a regular basis. So what we see is that most of the time she gets upset is when she is not able to understand why we are giving the kind of care we are giving. So utilizing technology to help them understand what it is that they're wanting to get, I think that's a big thing. Just to bring upon, I think what Sarah mentioned in terms of utilizing the iPads and Bluetooth-enabled technology to capture the basic vitals of the patients, showcasing the same to themselves, to these patients itself, to the elderly, is something which is going to help them understand, okay, I'm seeing a drop in my blood pressure, or I'm seeing a drop in my oxygen concentration whenever I'm sleeping. Maybe I should accept the care that is being provided to me. So trying to enable them by utilizing technology is a very big aspect that I'm seeing.
Thanks, Kaushal, for that. In fact, I'll take from there, using the technology, because we have Sanjay here from Neurology Corporation, where they're using a mobile phone which captures an image and provides you that feedback. So if I may ask Sanjay, is it a cakewalk or is it a disaster? So what do you think, and what it means for aged care?
Well, I would take a step back, right? I'm 54. Somewhere in 94, 95, when I started my career, I'd never thought that I can write a letter instantly and someone can read it on the spot, right? Communicating with someone outside my city was to write a letter, put it down in the land post box, wait for 2 or 3 days, and then probably it will reach him, or probably go to an STD booth and make a call. Remember, 94, we didn't have the mobile phone also. Today, we can write an email instantly and get a reply almost on the same time. So hasn't the level of communication gone up drastically in the last few years? I stopped going to the bank for the last about, I don't know, the last time I went to the bank was about 6 years ago to close my locker. I haven't gone to the bank. I don't go to a travel agent to book my ticket. So everything has come to this. The whole life, from a Uber cab to booking my air ticket, to booking my doctor appointment, to probably online, ordering something online, whether it's a mobile phone or my jacket here, everything I can use this tool to access today. Probably the only use case that I'm not able to establish in India, how we can take healthcare closer to the population where this is needed. So as an organization, as an industry leader, this is my responsibility. Can I take healthcare to the people on the mobile phone and sensitize them, hey, your blood pressure is going up or your cardiac activity is fluctuating? Talk to your doctor. Can I take it at a cost which is very, very minimal, affordable for everyone, and a quality care? And more importantly, can I take it to the patient or to the consumer when it's needed the most? Today, when we drive or walk around on the road, we found that ambulance zooming around the city, right? Can we reduce our dependency onto ambulances where we mostly see that the level of care which is provided through this ambulance care? And unfortunately, I'm sitting in a hospital. It's a very, I would say, negative statement, but ambulances are mostly used only as a transportation vehicle, 108 or whatever it is. The point is, a lot of care can be provided through mobile, all right? Now, adoption of everything else has gone up in this world for every kind of a services, and we all know in this, the only thing which remains largely untouched is healthcare. Now we have made healthcare available to the common people to check themselves every day, talk to their doctor over an application or speak to them over phone, and doctors would more than welcome the call from the patient or the data coming from the patient, which will enable them to provide care instantly rather than waiting for the patient to come to the hospital. So I guess in terms of adoption, this should not be a challenge. Now, in terms of quality of care, there is no second thought that the quality of care through mobile application, as long as this is validated and tested, is as good or as bad as going to your hospital, waiting for about 1.5 2 hours. Assuming you don't have a white collar, say, a white, coat syndrome, and then getting the whole thing done. So in a way, I guess the time has come to rapidly adopt onto the changes on digital health and see that the benefit of those technologies, the tools can be passed on to the people who are needed. And mostly people who need are aged population, parents, senior people at the home who find it extremely difficult for multiple reasons to go to the hospital and get the care. So this becomes an important tool, and for a period of time, I think whether it's a policymaker or provider or insurance companies or doctors or for that matter, family people should encourage those people to get the care or to consume care through these means and to see that, they are optimally cared and they get a, treatment when it's needed and the intervention is provided by the physician or by the doctor instantly. I guess the time has come for disruption, and we should take all the steps to see that those benefits are percolated down to the people who need the most. So when it comes to providing an affordable care, accessible care, and quality care, I think there is no better means to then leverage technology to the best of its capabilities today.
Trying to formulate my question because it goes to both presentations. One of my interests is to find out what works, and of course the mobile phone and new technology. We had a conversation earlier that's a very exciting development, and I will find out hopefully how it works and how well it works. But in terms of the comments you made about impacting at the end of an intervention, knowing that something is delivered appropriately and how it works. How can we follow this up? How can we make sure that we know that interventions work, and what systems would need to be in place for that is the sort of question that I would have. What is your experience? I'd be interested in hearing your experience about that.
Thank you so much, sir. That's a great question. I think to understand a bit about what works in terms of last mile delivery of interventions, essentially it would mostly be the concept of trying to understand the impact if a particular intervention has actually taken place or not. And most of the times, especially in a country like India, connectivity in a physical standpoint is not that great. We have what are called as ASHA workers, who are field level professionals who are going out into villages to conduct health camps, to conduct any kind of implement government schemes with regard to healthcare or with regard to education. Now, what happens is they go around to villages maybe once a week or once a month. And if there is any kind of implementation that happens at that time, right, for them to again go and check up on that again and again, the loop around period is a month that typically happens. So these are the kind of problems that we've seen which are being faced. Another example, if I may, is for a project which we did with ICMR, India's premier medical body, research body in Hyderabad, where we conducted and designed a complete customized solution on anemia detection, screening, detection, and tracking. What we did was integrated a solution with the blood analysis machines, which were taken out into the field in SUVs hooked up to car batteries so that the blood analysis can be done out in the villages itself. So what that did was cut down on the overall time period of detection up to dispensing of medication from 4 to 5 days down to 45 minutes. So this is the ways in which we are seeing how we can leverage technology rather than overdoing it with,
cutting edge tech, it's the low tech solutions are what will both be adopted and continue to be used beyond the basic implementation period. I think that's what I believe is what works. Most of the times, there are a lot of programs which come in place for a period of 1 year or 2 years, where there's a very intensive support by the government, by certain organizations. But once that is done, at the end of that 1 year or 2 year period, it goes down to the local governance, to the local stakeholders, and to the beneficiaries themselves to try and continue utilizing these technologies. So what works best is if it is simple, if it is easy to use, affordable. And I think that's how we'll be able to see an effective utilization at the last mile.
Yeah. Thanks, Kaushal. That was really insightful. And also when we look at the output, outcome, and impact, because whenever we are adopting certain things, probably the decrease in IMR, when we see in India, I can relate well, the programmatic changes that were done 30 years back are yielding results sustainably, continuously, and even today. The delivery at institutions, which was relatively low just 3 decades back, today we have almost 95+% of deliveries happening in institutions. And to a large extent, they are also connected and they're having this MCTS, maternal child tracking numbers and systems through the HMIS, Health Management Information Systems. So the adoption of technology, while at the individual level can be assessed immediately, when we look at the scale, the public health scale, for the impact, the time lag will be there. But when we look at what works best, the influencers, the conditioning factors, and the actual outcome might not be dependent on that particular technology. Because if it's like we have worked on the models of technology adoption, the earlier Davies model on technology adoption using intent to use, ease of use, and potential inside internal motivation for use of technology. So these are all the social, economic, and other context which will make them to adopt something. But if they feel that, look, this is going to make my work easier. He was talking about the ASHA workers. Today, they are the end mile frontline healthcare professionals in India, where more than 64 national programs we expect a single person to handle. So it's a humongous task, and most of the apps, most of the health systems are still working as vertical applications. So we have an amazing app for Nikshai, for the tuberculosis control program in India, where the registration happens, patient compliance happens on the mobile phone. But what we are looking at is an integration. When we are talking about care, it's not the curative care. It's a spectrum of care, from preventive, promotive, curative, and rehabilitative. And the percentage of people who require any form of this kind of medical or clinical intervention is only a small fraction. So it's the inverted Pareto. 1 minus X is the larger problem, for which aging, when we are seeing the aging in place construct, has non-health determinants. It has got nothing to do with I mean, like when I'm saying nothing, not a major part to do with the clinical component or the sickness scare of it. It is how the accessible the societal amenities are, whether the residential environment is conducive for an elderly person to have their activities of daily living. So these are all some of the things, and today the technology is able to provide and surmount most of these common things. We have these sensor-based lights and other things which provide a lot of support for the elderly, and the infrared cameras can detect if there is a fall. Fall prevention has been a very, very well sort of addressed problem with the technology. I think more than 16 companies today are working on detection, because after the person falls, that's not what we want them to have. So we want to predict, and any change in the movement or gait is sort of like machine learning algorithms detect it and say that there is a probability of this person fall in the next a month, week, or whatever, so that the corrective and preventive action can be taken much before that. So whether it works, yes, at an individual level, measurable outcomes can be done. But at a larger public health level, it might take some time. And we certainly would love to have larger cohorts, multiple settings for such technology adoption studies, which is what the whole intent of a cross-country network that we are building, to see that like what works in India, is it the same in some other context? Because the use case can be totally different for a same solution. So you want to add something, Angie? Okay, so in that context, probably I have a question for Sarah. With regards to the, I mean, most of us, I think, in the room are convinced that yes, technology does work. But while we are at it, what are the strategies that can be employed to ensure that the technology in elderly care respects the privacy and dignity of individuals? Because some of them are intrusive, some of them assume that because it's a machine, so it takes the information. And we have seen a lot of Hollywood and Bollywood movies in India where the technology, like actually the AI ML, so works as a machine, I mean, disrespecting the emotional component of human care. So what is your view on that, Sarah, if I may ask?
Yeah, thank you. So I think the important element to any use of technology, and then obviously the use of AI, is consent. And so we have a duty of care for every resident and every aged care person that we treat, is to get consent. And that's informed consent. And I think we understand that, particularly in health now, that in Australia, it absolutely has to be informed consent. And that's not just saying, well, we're going to use this technology. We have to go into the detail of what that means. And we also have to talk about the sort of the risks associated with that, particularly from a cybersecurity component as well. So we do that as a part of any aged care person that will be utilising our technology, where we'll be caring for them. That is part of the process of them being admitted. I think the other component, though, that and I'd be keen to hear from Andreas in relation to AI bias. And so we're collecting all of this data now, and we're applying algorithms and we're utilising AI. But, you know, what is it for someone who is disadvantaged or someone that is living remotely or regionally? And what is it that where patients have got multiple comorbidities, and how do we I think that's a question that I don't know the answer to, and that's why I'm asking it really, is like, how do we ensure that we're safe in this space? And I'm not sure that we've really, certainly here in Australia, and from what I'm seeing in relation to health, is bias is something that we really need to consider when we're pulling data and then making assessments and applying algorithms and then saying, well, this is a technology that will fit you, or this is the equipment that we need to use for you.
Thanks, Sarah, for that. If I may ask Lee Martin, with regards to the public-private partnerships, because many a times the innovation is from one sector, but adopting it in a larger sector will certainly require the buy-in from the governments and the policymakers. So is there something that, with your experience, or if you can throw light on how these public-private partnerships play a role in advancing the use of technology, and how we can sort of go ahead in this particular domain?
Certainly in our case here at Leela and Holmes Barossa, some 5 years ago, I was given quite a large federal government grant to introduce technology through the use of robotics. But since then, it's actually been quite a struggle to get further funding for robotics. So I've been working with a lot of robotic companies in trialing different robots for quite some time. And then what I've discovered now is it is actually far more efficient to lease robots rather than purchase them. That way the technology can be kept up to date, and if one type of robot doesn't work, then you swap it out and try for another one. So I'm actively looking for further sort of partnerships in the robotic sector, because I firmly do believe that there is a place for robotics in the aged care sector, but the robots themselves need to be further developed and designed more precisely for the aged care environment, be it whether it's in an aged care home or in someone's own home that's aging or with a disability.
Thanks, Martin, for that. And also, when it comes to rehabilitation of elderly, one of the common things that we see is like the challenges are not same as in the general population. So we have Professor Savita Ravindra from the physiotherapy and rehab. Can you share your experience, ma'am, with regards to the use of technology in elderly care rehab process?
Thank you, Nanda. We at Ramaya have been working extensively, I think, from pre-COVID. And one of the taglines that we were using was that we wanted to keep people healthy, the older adults healthy in the community. And so with that, as I think we initially began with trying to run a lot of group exercise programs, because I think that was one component of keeping them healthy in the community that needed you to do that. COVID brought in a lot of difficulties because we suddenly couldn't run all those group programs. So at that point in time, like everybody else, we shifted to using the Zoom platforms and the others, because that came as a request from the community that were actively engaging with us. And from 2020 to date, they don't want to go off that exercise program platform. So 2 times in a week, like on Mondays and Thursdays, we have more than 100 older adults within the community of where we are at Ramaya who come on board, and usually always come maybe 5 minutes ahead of us the moment we open the platform. They are very comfortable with using technology, which we struggled with. A lot of them are sometimes not able to find support, transport, and other facilities to come to our center where we still run physical programs. So I really believe that adapting to technology is not going to. We also get them to where some of them who have other comorbidities, we get them to wear the wearables that we've connected, so we can read some of the parameters while they're exercising with us, so we can ask that person to slow down or stabilize, steady. And we do get them in maybe once in about 4 weeks to 6 weeks to come in just for us to do a visual, personal, physical examination. Some of the feedbacks that we have got post-COVID extended from sentences like, "You kept us alive." And so it's very encouraging. And I believe technology with the older adults is not impossible. In some situations, it may need a bit of support, but it's completely doable. And I don't think that the adaptation of technology will be an issue with them. I don't think so.
Thank you very much, Professor. I think now that we've discussed the technologies, and it's very clear that as we have billions of connected devices, the challenge will not be really in buying and developing the technologies, but in actually getting the workforce ready and overcoming the resistance to change in adopting the technology. So Professor Raj, can you tell us some of your thoughts around being work ready and what we really need to develop our future workforce?
Thank you, Angie. I think we all are living in this very dynamic environment of changing landscape, whether it's in terms of technology, whether it's in terms of our environment, whether it's in terms of what we all faced for a couple of years when COVID. So I think it's really, really important to create most enterprising graduates and people who are absolutely work ready. And I think for that, it's so important to look at two specific angles. The first one is our curriculum and our training. That needs to be very contemporary. That needs to be very dynamic. And second part, it needs to be co-designed. It cannot be just designed in isolation by just, let's say, if I'm an academic or a dean, I just sit with few academics and design some curriculum, whether it's for allied health or for something else. It's really, really required a co-design process where you bring in people from industry, people from community, you get end users, and you look at the genuine landscape changes. And then because we are preparing these graduates for the future. So it's really, really important to have those enterprising skills embedded within the curriculum and to train it accordingly so that we have these really empowered graduates who are willing and ready to tackle the challenges which the environment, the constant changing environment is throwing at us. So I think that's a huge responsibility of tertiary education providers or other providers which are playing in this space, Ajay.
Thanks, Raj, for that. I have Dr. Amrita here from World Health Organization, Seattle region. From non-communicable diseases, like which are the chronic diseases, use of risk scoring and risk factors, and a lot of wearable technologies today addressing the cardiovascular spectrum. So with regards to aging, with your experience, can you throw some light on how do you envision the use of technology for aging as a domain across?
Yeah, thank you. Thank you for your question. Yeah, definitely technology has a role, and we have been seeing in our day-to-day life and in our day-to-day clinical practice as well, who are clinicians here, that it is changing lives of the people. It is giving them kind of more empowering them. It is empowering them to monitor their health themselves and to take actions at the right time. So like they can monitor their blood sugar, they can monitor their blood pressure, they can monitor their oxygen saturation level. This is all technology. And they are empowered and they can make their decisions, they can take actions immediately. So these are all very helpful things. But unfortunately or fortunately, it is not in reach of everyone because of many reasons. One is the digital divide. Yeah, people have this, but studies, we assume that everybody is able to use technology and smartphones, but studies say that it's still the ability to use technology among older people in many countries is 30 to 40%, but almost half than the population, general population. So it's still, there is a reason, there are reasons, like there are things which we need to address. One thing is this, and then they are expensive. They are not affordable at times. So people, they can do, but they cannot afford it. So having a technology which is affordable, which is then accessibility. When we talk about older people, we need a technology which is accessible. So we make any technology, maybe if the person's vision is poor or something, and we make an app, he has to read in that phone and the language is not appropriate or the font is not appropriate. Sometimes it is not usable for the older people. So accessibility, affordability of the technology, and then, knowledge and usability. So as Dr. Nandakumar mentioned, that whether it is, you mentioned some Davis theory, I think it should be adaptable, but why should I adopt it? Whether it is usable, why I should use it, those three questions you mentioned, I really liked it. So there are issues. So we recently had a workshop with ITU in Thailand, and we discussed about it, like how the digital interventions can improve. Like we have examples from Ireland, Australia, Japan, everywhere the digital interventions are improving the lives of older people. And in fact, NCDs and many other areas of public health. But still there are issues, there are many challenges when you talk about lower middle income countries, and definitely, but with these kind of motivation and encouragement and so many experts already working in this area, I'm very hopeful, and definitely technology is the answer. along with, and technology should not be seen as the kind of replacing human resource. They are supporting human resource in any case. So I'm really hopeful and I like the discussion. Thank you very much.
Thanks, Amrita, for that. I think we are coming close to the session. We are supposed to close at 5 p.m. Indian time. And keeping that in mind, I would request my co-chair, Angie, to provide her perspectives, and probably I'll close the session. On to you.
Thank you very much, Professor Nanda. And thank you to our amazing panelists for all their insights. We've really had a deep dive into understanding the current landscape and how technology is being used in elder care, both in urban and also rural and remote, and also many of the different impacts that that can have on the populations, both urban and in remote areas, but also very much highlighting the opportunities presented by the technologies. But nonetheless, the challenges and the barriers were also uncovered by the speakers, by the panelists, and by many people across all our discussions today. Many themes emerged, amongst them also the mental health challenges and loneliness, and the human touch, and the importance of co-designing with the consumers to be able to make sure that we're developing appropriate models of care that can actually be sustainable and long living in the different communities that we want to do. Thank you for sharing with us the best practices in your organizations and the success stories. And I'll hand over to Professor Nandu to deliver the final comments.
Yeah, thanks for that. Now, I was just summarizing, and I felt technology does work, but we want the hilt, that is the human in the loop. And when we are looking at this word co-design, we mean like it's like the multi-stakeholder perspective. Because in public health parlance, we use the stakeholders as the people who are not only the beneficiaries, as against that, the people who are also around that system. So in that sense, like if we have the human-centric approach, which Raj mentioned, like what is that we are trying to attempt using this? Are we trying to make it a better place ultimately? With that in mind, I'm sure that like the modern technology is here to stay. And if we can leverage it for the benefit of both the providers, for the receivers, and also for the entire supply chain in between. Because when we look at the caregiver burden, especially in elderly care, I mean, like when somebody comes, we forget to ask, like, how are you? I mean, like they might have been taking care of the person, especially in long-term care, palliative care, and they might be requiring that support. And some of this technology can be adopted and help to ensure the ease of burden. So if I know that my mother or father is safe, I can probably engage in an activity which will free both mentally, physically, and socially. So in that context, just to sort of like summarize, technology does work and it does not come without challenges, but those challenges are surmountable. We can provide affordable and accessible, and there have been best practices, success stories, and it's only a matter of scale. So we need to sort of like use what is working at X place, using your batteries to charge the analyzers, to use it for something else from solar or sustainable. And one of the threads which we haven't touched, which both Angie and I discussed in the afternoon, was while we are going for these technologies, is it sustainable? Because ultimately the SDG is the guiding force, Sustainable Development Goals, where we are saying accessibility, availability, reducing hunger, providing healthcare. But is it going to be environmentally safe? Is it going to ensure that it is going to be there for the next 100 generations that we are talking about, and we are on borrowed time? So the power that we use for powering some of this technology also should come from clean technology. So that is something that we need to keep in mind. And I'm really humbled by the wisdom of the team and the table that we have had together in this session. And I am thankful to all the participants. And I'm sure that some of you would have had questions which you would have put in the chat box. And we will certainly make an effort to write to you and connect you with all the team here so that we can continue the journey that has been started over here. So I thank all the panelists, co-chair, and the people who have participated today in this very interesting conversation, both within India and at all the 6 countries from where they have joined. Thanks a lot. Thank you for the session. Thank you. Probably the Zoom. Yeah. Absolutely. Yeah. And probably we will sit for a minute because from morning we have not thanked the people we have a small memento to be given to the people who have been sort of participating in various activities, at least physically over here. So we'll request the team, probably Neha can come inside and yeah.